Good morning, everyone. My name's Steph Poole. I'm non-exec director here at Humber Teaching Trust. Hope everybody is well this morning and welcome to our Trust Board meeting. It's 9:30, so we're going to get started. So first of all, apologies for absence. The first one I have is from Caroline Flint, who's our chair, who's not able to attend today, and we send her our very best wishes. So you've got me in the chair today for this meeting. Do we have any other apologies this morning?
Yes, Steph, we have them from Karen Phillips, and Vicky's here on Karen's behalf, and Lynn, and as you know, Claire's stepping in for Lynn.
Okay, so we've got Claire here, thank you, and Vicky. Brilliant, thank you for that. Was your hand up there, Michelle?
Sorry, it was, but Stella mentioned it that obviously there's ongoing apologies from Lynn, but Claire in her interim Chief Operating Officer capacity. Thank you. Sorry.
Okay, thank you. Yep, so we are quorate. We've got a full complement of exec and non-exec directors today, who you can see on the screen. So first of all, declarations of interest. We have a paper on declarations of interest. Has anybody got anything to add to what's in the paper? And just to remind you, as we go along the meeting, if there's anything anybody needs to declare, just do so at the start of that agenda item and we can record that. Thank you very much. So we'll move on to the minutes of the Public Trust Board meeting, which was held on the 27th of May, 2026. First of all, can we approve these as a true record of that meeting? Does anybody have any amendments or additions to that? Everybody happy that those are a true record of that meeting for everyone who's present? Yeah, seeing some thumbs up, yeah. Okay, those are approved as a true record. Can we move on then to the action log and matters arising and work plan from that meeting? So we've got a copy of the action log here. There are 3 live items on that. One is to do with the electronic patient record optimisation update, which is due in September. So we can leave that for the time being. The second one is to do with Quality Committee Chair, which is you, Phil, undertaking a planned visit to Town End Court following CQC and inspection. I see that's scheduled for September, is that right?
It's been rescheduled for September, yes. Originally it was July, but it's been rescheduled for September.
Brilliant. And then we had review System 1 task policy, policy information when received, and that in June. The board has approved the policy. It's been widely circulated. Due to present a clinical oversight group on the 22nd of July, an update will be provided to the Quality Committee on the 20th of August. So we've got the processes in hand for that.
Yeah.
Thank you very much.
Yeah.
Superb. Anything else in relation to matters arising? Anything on the work plan that we need to be concerned about? No? Jolly good. Thank you very much. So that's the sort of initial formal bit of business done. As you all know, every meeting we like to have a service story or a patient story to sort of set us in the right frame for the meeting. And today we've got a service story from Child and Adolescent Mental Health Pathway and the Thrive approach. We have Justine here. So there you are, I can see you on the screen. To talk to us about that. Justine, we've got about 10 minutes for presentation, about 10 minutes for questions and discussions, if that's okay.
Yeah,
so I'm just going to hand over to you to introduce that. We've got a short paper, but if you'd like to introduce that and just give us some headlines. Thank you.
Thank you, Steph. So this is a follow-on to a couple of presentations that we've done before, I think, to this meeting. It's 18 months, maybe 2 years now into some of this work, and it's been a great learning opportunity for us to review our pathways across our CAN services and make sure we get that approach of getting it right first time. So really pleased to be here. Karen's also come with me because Karen's been central to some of the work that we've been developing and is due to launch very soon around our risk support services and admissions avoidance. So 10 minutes, I will just share presentation and we'll get going. It's just coming up. There you go. Can everybody see that okay?
Yeah.
Is that sharing? Lovely, thank you. I can't see hands, so we'll save questions till the end if that's okay. So just a brief reminder of what the Thrive framework is in CAMHS and mental health. So this is a person-centred, needs-led framework, which is dynamic. So it's a circle, so you can move around in terms of levels of risk. So you can go from having no risk to a lot of risk, or you can move gradually increasing risk through the circle. So it's really important that our services are designed around that approach and are dynamic to accommodate it. So it's not a new framework, Thrive, but it's just a reminder to everybody of what the local framework is that all services, not just mental health services, but all our community services as well, identify with to support children and young people. Also, just a reminder again of our initial pathway redesign. Don't know if you remember the initial slide when we set off from this work, and it was very much higgledy-piggledy, a little bit like Spaghetti Junction. We needed to streamline all of that out because families were coming through the pathways and it wasn't seamless. It needed our services to work very much more carefully together. So we've designed this. And what I will say about this is it is an evolving piece of work. So already, as we're redesigning our front end of the services, which I'm going to go on to talk to you about, it's evolving as we go through this work as well. But we are able to demonstrate some of the real impact of what's happening across the redesign, and it's very positive and beneficial for children and young people. The pink again is a reminder to everybody of those services that sit in the early intervention side, the based really within the wider community support, they interact carefully with our voluntary community social enterprise services as well, who are there to support children in communities. And the blues are more specialist services that are held by our treatment CAMHS services and intensive support side. So just part of the redesign that we've been doing is looking really carefully at that front end into our model, into our pathway in our services. So we've used the getting it right first time approach. The whole function around some of this is to improve access to early support. And you'll know there's a real driver for that coming through national policy and documentation that we're getting to look at how we support children's mental health services early on, so we can reduce that need to wait on long lists for specialist services. And we know if we intervene early, children are more well supported and do manage to maintain the risks within the communities and not develop worsening mental health. So mental health support teams have been a key part of that. So this was an initiative about 5-6 years ago that was brought in by government, has been continued luckily for us all, and is one of the drivers in the long-term plan as well. So in Hull and East Riding now, we're almost covering the whole of Hull and East Riding. We have one pocket of area around the Halton Price corridor, but what we've done is we've used our already existing services in early support to monitor that and to make sure that there's no gaps within the coverage of our teams. We're also looking very much at the routine services, moving into a centralised front door. So we did have something called Contact Point. It's still there, but now we've got access to mental health support teams in schools. We need to review that. And what's happening is we're looking at all our routine services, centralising together so that we can offer more community and family support. And that, I'll talk about that as I go on to, because that's actually altering the front door into our CAMHS services too. And by doing that, by having a really good understanding of the routine services and referrals that are coming in, it's helping us to really monitor referral analysis. And already seeing that the direct correlation there is between mental health support teams increasing referrals and more access, lowering our CAMHS services as well, our referrals and need for those specialist services. The referral analysis also enables us to work with the GPs find out where the referrals are coming from and track that support. And it's putting us on the front foot for when we move into a neighbourhood model of care. Within this part of the service as well, there's the family and community support, which is strengthened very much, as I said, through our voluntary community, working with organisations such as Mind, Matthews Hub, Bernardo's. And then we've got the digital option and the Connect websites, which is also part of our offer as well now, supporting access, which is a real target for us in those early intervention services. Just go through into the next part of the service. So now we're getting into our more specialist services. So this is the pathway into specialist services, formerly known as what we'd call core CAMS. And as I was telling you about, as we're starting to really transform our front end of the model, the blue, which formed part of the family partnership area in core CAMS, is now merging very much around mental health support teams, which is a good thing because it means that children are very quickly being able to get through into those yellow areas, which are our treatment waiting lists as well. We've been we're going to tell you about the success we've had in our waiting list as well, but I'll wait for the slide on that. So I'm just going to hand over to Karen now. Who's just going to talk about those risks type services and crisis area.
Yeah, thank you, Justine. So yeah, I'm the service manager for intensive mental health services and eating disorders within CAMS. So the focus of the work that we've been doing is around developing the family day service, which is a model of working which will support that admission avoidance. It's a function that has been identified through the new NHS England developmental specification, which has a number of functions, but this particular one is regarding day service. The really innovative work that we've done, we've worked with young people and parents and colleagues across both locally, regionally and nationally to set up this day service, is it will have a focus on family, which is very much in line with the NHS England guidance. So we'll be admitting a whole family into the day service for a concentrated, intensive piece of work over 12 weeks, and then following them out into the community, working alongside our core CAMS and other colleagues and external agencies that might be supporting that young person long term to ensure that those changes that we've made are consistent and continue on into later life. The safe space, which is currently managed by Mind, which is currently in a location is in Beverley Road at their base. We have decided to relocate to the Walker Street to the provision that is now the day service. So during the day service will run, and at night time we will have the safe space facility. So that will mean much more closer working with our crisis services and with our voluntary sector colleagues. We've also done some piece of work on Contact Point. Contact Point used to manage all the crisis team calls during working hours. We have recently changed that so that all calls go through to the crisis team. However, we put a really clear guidance in across our CAMS services that there's no wrong door. So if a young person was to access any of our services in crisis, then there is a process that we would follow, that we all have signed up to support that young person and make sure that they get to the crisis team in a speedy and timely way. Some of the other things that is important to note is the new Mental Health Act 2025 guidance around least restrictive for autism and learning disability. I'm really pleased to say as an organisation that we have been doing this for a very long time, but we are also looking at, as part of the day service opening, of providing a all one CAMS team integrated pathway meeting where we will be identifying young people with risk or significant complexity and how we can support them across all services and have a real joint approach to that. So that's really going to be really helpful and reinforce that one CAMS team offer that we've already put in place and working with. And then lastly, just very quickly, the eating disorder intensive support, our EDIT team, continues to support young people with eating disorders in the community. We've had a significant drop in eating disorder referrals, both to our inpatient and to this team, due to the amount of work that we're doing in the community, and actually is unusual to the region and nationally. So I think that the fantastic work that our EDIT team, we're really showing dividends in that currently, and is being nationally recognised, particularly around our reduction in NG feeding. So yeah, people are interested in coming to see us to see how we've made such a significant change in eating disorder presentations. That's it for me, Justine.
Thank you, Karen. We're really proud of that work, aren't we, and the speed that we've been able to mobilise this. Just touching then on clinical models, not for a great deal of discussion, but it was just to say that those are the models now that are really picking up traction to support the whole teams around embedding the shared values, which are driving the one team approach, which is the ambit, which is thinking about how I'm thinking, how you're thinking now, and how we think together and share challenges and problems, and the art, which is the regulatory framework around attachment and emotional regulation. Just going on to the evaluations, and we're nearly through. This is part I nearly told you about earlier because I'm very excited about this. So what we're seeing now are these areas of celebration that we're able to measure through our pathway improvement. So we've got a decreased time now from referral into treatment. For the first time in a long time, there's a couple of outliers on certain specific pathways. On the whole, 18-week compliance in CAMHS is a real goal that we've achieved that we're really proud of. We've got the reduced waiting lists as well. As I mentioned, that direct correlation between being able to see children early on and in schools and in their communities, and that reduction into referrals into specialist CAMHS. And certainly from Karen's point of view, in that risk support, we've seen a real reduction in children going into crisis as well. Increasing contacts, we're monitoring on productivity. That's work in progress as well. Still a lot of work to do, but we've got a positive picture improving. Reduction in re-referrals as well. So what we're doing is tracking the children that are being seen in the community and are being seen in schools or by our lower level skilled workers, that work is successful, and we're not seeing children being brought back in very quickly afterwards. The whole idea and the premise of that is that we build resilience in the community so that doesn't happen. So it's a really important part of our monitoring processes. That we're seeing a reduction in our did not attend or was not brought as well. And then we've also got, it's not perfect yet, we've still got some work to do. There's some complaints as well, but they have reduced down. And next slide. And then just the final slides around learning for us, and you know, what has helped us succeed with this, because it's a really big piece of work. And when I look personally at how the teams have started to work together and now have that philosophy of a one team approach around children that are coming through CAMHS, it's such a positive place to feel. A lot of the success of that, looking back, has been on centralising our processes and centralising our leadership teams as well, making them think about that our family is not mine, or that the teams are evolving together around those children, looking at needs and skill sets for development. The children and young people centred care, voices services users in that design, the Humber Youth Action Group, Recovery College, all those other functionalities that we have that really help design our services. Supporting the teams with challenge, you know, the clinical models around that, developing that psychological safety, that it's actually all right to have different opinions. We really value that. We really want that. We want to know 100 reasons why something won't work well from our teams. Let's embrace that. And that's a part of the learning and the philosophy we've tried to drive through into teams, which fits with the sharing of values. But alongside that, being quite clear operationally on what we're trying to achieve and when we need to achieve it by, so you don't get the tension of drift. And then just to put in about the integrated, and I think we integrated service, working with other agencies and services, because this isn't something we can ever do alone. And it wouldn't be successful if CAMHS just felt alone. They've got to fit in with that wider system working as well. I won't go through them, but I put in there our shared values of the one team approach that we use at the point of every meeting we have where we all come together. We make sure we focus on those particular values. And that is the final slide.
Thank you very much for that. Really good presentation, thank you. And a really impressive piece of work in such an important area. So thanks to you and the team for all the work you're doing there. So if I can just open the floor up then to any questions or comments that you have for Justine or Karen. We've got about 10 minutes. Carrie.
It's fantastic work, and it's really exciting to listen to it and to see the developments that have taken place, particularly as a relatively new NED. It's really good to see that. How you were talking a bit about, well, you talked a lot about partnership working and working across the pathways, which sounded like it was paying real dividends. How does it feel around neighbourhood working and GPs and PCNs? How's that sort of panning out? It's just a query. There's no, no side to the question. I just wondered how that was doing now, because I think previously when I worked in the clinical commissioning group, I used to find it quite difficult with GPs and primary care engaging. So I just wondered how that was going across Humber.
Yeah, I think it's a really good question. It's something that we're monitoring really closely around the development of neighbourhood teams and our involvement in those. Hull and East Riding have both got their own neighbourhood teams set up. We engage with that in terms of our senior leadership and clinical support. But I think the really exciting work for me is that what I was talking to you about in terms of monitoring our referrals that are coming in across different patches and different localities, because that's the real population health stuff that's driving, isn't it, neighbourhood health teams. So we see that a lot where we get GPs sending in lots of referrals or schools, and then what we're able to do is look at how we respond to that within our services. So it might not just be CAMS, some of our 0 to 19 services as well in school nursing. If there's a problem of if there was a lot of high suicides coming from one particular area or self-harm, we target that specific area with the resources through the neighbourhood teams where possible, with schools or with any other agencies that might be within that neighbourhood as well. And neurodiversity is another area where very much neighbourhood teams are identifying that a lot as issues that they want to address, because GP surgeries are getting overwhelmed by children and young people coming in for a behaviour problem. So that's a really good example, similar to CAMS, about where we're adapting to be able to go in and support localities. But it is work in progress, Carrie, I would say, still, as they're evolving.
Yeah, okay, thank you.
Thanks, Carrie. Sarah.
Thank you. Great presentation. And I know we've seen the sort of the journey of this through EMT sort of quite regularly. So really positive. I think just a couple of comments and one question from myself. So I really like the Think Family approach with the new day service, and that really aligns with the new national statutory guidance on working together from a safeguarding perspective. So it's really good that we're dovetailing them transformation models with also our safeguarding models of care as well. I think the eating disorder stuff is just phenomenal, and we really do need to celebrate that, because it is excellent how we've avoided all those inpatient admissions. I loved the outcome slide. I think this is an excellent example to the board on the work that we're trying to do and demonstrate impacts and outcomes for our patients. So really excellent to see that we're not only focused on sort of quality and patient experience, but we've also got an eye on productivity and efficiency as well. So that was really good. And then my question was just, I was really interested on that front door stuff around the analysis work you're doing around the sort of referrals and understanding those referrals. And I just wondered if you were using any form of digital technologies to support you in that, or whether that was more of a manual type of work. I was just keen just to understand that bit of detail. I wasn't aware of how you were doing that. Thank you.
Yeah, so nothing, no specific digital platforms. We're just really using the data that we draw from System 1, or that local intelligence that staff have from sitting in the front door and seeing the same referrals coming in over and over. I mean, obviously they're counting them and they're tracking them, but we don't have a specific digital platform helping us to do that.
Okay, that might be something, Chair, for us to maybe just consider. I don't know if there is anything, but maybe something for us to explore. Thank you.
Thanks, Sarah. Yeah, that's something I'm sure we can take away and have some consideration around, because it is applicable obviously to other areas of work as well. Thank you. Kath.
Yeah, thanks, Chair. Thanks for the presentation. Really interesting. I also liked the outcome slide. I thought that's really, tangible evidence with the data set behind it about the improvements you've made, and obviously looking at the quality. You talked about the complaints have been reduced, which is really positive to see. I was kind of interested in on the, the positive side of things. So the feedback from families and children who are accessing the services, and what does that look like? And are you seeing any improvements in, I don't know if it's FFT you use or, other mechanisms in the service to assess what the family feedback is?
Yeah, we are monitoring that as well, Kath. I didn't, we did have a slide on some of that, but I was trying to stick to the 10 minutes, so can follow that up for you as well. Absolutely, those are the families sitting in that front end of the service, they are in, and the teachers, the whole people around that. Some of the comments that we get back in are so heartwarming, really. They are just so grateful and pleased with the services that they're getting in schools, and that's continuous. Our specialist services, we do evaluate through, we've got something called the family partnership side. So that's 6 weeks where we work with the family to see if we can avoid any need to come through. So they're monitoring that as well in terms of family feedback. And the other big part that we use is through our young people as well. And they tell us directly how they feel about things, and we monitor that. We do look at friends and family, but that is something we could maybe draw more into this work as well, to have a look at that, because we've been targeting it more than using the friends and family approach.
That's brilliant, Justine. And then just to comment, myself and Pete Beckworth were at a meeting yesterday, and the Connect website and work you've done came up as a really positive piece of work that's been taken forward by the team. So, kudos to you, well done for all of that as well. Thank you, Chair.
Thanks, Kath. We have Andy next.
Thank you, Chair. Morning, Justine. Morning, Karen. Morning, everybody. I'm a new NED too, but I'm also new to the NHS, and so seeing presentations like this, I find extremely useful, and it's fantastic to see that services are being looked at and improved in this way, and the outcomes for the children and young people is absolutely fantastic. So from my perspective, I really enjoyed that presentation, found it extremely useful, and it's great that to see this happening. As other colleagues have mentioned, I too found the outcome slide really helpful, and I was wondering whether it'd be possible, perhaps offline, to see some of the underlying numbers behind that, because it really does look marvellous. It'd just be nice to see some of the quantum improvements there. You maybe didn't want to include that because it would extend the time, but if it's okay, I'd quite like to see some of that offline, if that's all right. But thank you. It's a great work.
Thank you.
Thanks very much, Andy. Michelle.
Yeah, good morning. Thanks, Justine and Karen. Great presentation, and great to see the evolution of the work as well. Because I think when we started on this, the flowchart was a bit like, probably worse than the bowl of spaghetti, wasn't it? I referred to it as. So I think it's really good, and hopefully people that are looking in can really see the work that we've tried to do to increase that accessibility, but also that reduction in the repetitive nature. Sometimes I want to repeat yourself and things, which gets frustrating. So thank you for that. I absolutely completely endorse what Sarah said about the edit team, the eating disorder team. I think that's absolutely phenomenal, and I think we need that. That's exactly what we need to be looking at across a lot of our services, about that shift from inpatients to outpatients. And we've done a lot of that in mental health, and there's a lot more we can do, and a lot more we can do in community. So I suppose for me, it's about, let's not lose sight of how we can share this process. And this is probably one for Claire as well, with the rest of the ops team. I know that you are doing that in some of the transformation stuff, but we've got some information there that says this proves to be successful. So I would see what we can utilise in relationship to it. going forward. Obviously, this is exceptionally topical because it's one of our real high areas in relationship to waiting list, demand, capacity. So we've got to keep at it. So I think for me, this isn't just the end of the process. I think, as you alluded to, we're going to keep going and keep developing. I just wondered if there's anything that you specifically needed or would be useful from the board point of view. I know we have lots of conversations at the exec team about it. But if obviously you've got all the board here. So it's a great opportunity. If there is anything that you feel further that you require or would like the board to be aware of or help with. But fantastic presentation and work, and I know the time that's gone into it. So thank you. And you are making a difference to patients and families, which is what we're here for. Thanks, Justine. Thanks, Chair.
Thank you, Michelle. And I do find you all really supportive anyway, all the execs, particularly. If you need anything, Pete, is quite happy to come help us with the states, and Claire around the productivity. You've been key, central to that, a great support. But thank you, Michelle. If there is anything, what we are finding are, you get unintended consequences as well. We're finding, little challenges that do pop up, particularly, one of them that I can think of right now is that how the front end of that model, how having the mental health support teams working really closely with core CAMHS, has left there's some areas that we've got to look at there to get that tightened up so we don't have families thinking where they belong. But other than that, I think the whole thing's just gone so well, and a big credit really to the teams. Well, I guess the point I was probably trying to make when I was saying that was we're feeling really confident around when these unintended consequences do come up that we're managing them, and we know you're there if we need anything. So it just feels a really good place, really working within the team, to be able to do that. And it gives them a really good sense of agency, I think, when we do hit a bit of a challenge and they're able to sort it out together. It's been what we've needed to do in CAMHS for a long time, just work together.
Thanks. Thanks, Justine. Kwame, last word to you.
Yeah, thank you. I'll keep it brief. Excellent presentation, and the work you've done is phenomenal. I know people know that I don't use words like that easily, and the whole idea of streamlining young people's services to make sure that processes are clear has been recognized as a difficulty nationally, and the fact that you've cracked it is wonderful to see. I have sent you an email which has come from the National Getting It Right for the First Time GEF. They have somehow heard about what we've done here, and they want to see whether they can do a piece of work to see whether that approach can be translated not only within our services but outside our services. So when you get a chance to look at your inbox,
I did see it. And it includes neurodiversity, doesn't it, from NHS England? Yeah.
Yeah, it also came yesterday. Thank you very much.
Thank you. Thanks, Kwame. Thanks so much for your presentation, Karen and Justine. First of all, thank you for the work that you're doing. Please pass on our thanks as a board to your teams who are doing all the work on the ground, which is absolutely brilliant. And obviously a couple of asks from today's meeting. Please could you send the slides round to everybody afterwards, and also the supporting data around outcomes, which would just be so helpful for us to have a look at for much wider reasons as well. But thank you very much for your attendance today. You're welcome to stay, but equally if you need to go, then please do so. Thank you very much.
Thank you. Thank you, everybody.
Thank you. Bye.
Okay, thank you very much. That was really good, really nice and uplifting way to start today's meetings. I'm going to aim for a break at about 11 o'clock this morning, just for information. Hope that's okay with everybody. We're going to move on the agenda now. Firstly, Chair's report. Caroline has helpfully provided a report for us today, highlighting a few issues. I won't dwell on it too much, but just to say that the Chair NEDS and Chief Exec appraisals round has been completed. We've had some well-attended Council of Governor meetings, and we've had some good engagement with external organisations as well. We've got preparations underway for CQC inspection in due course and well-led review. We've at the very start of a campaign to recruit associate non-exec director. We've been having some strategic discussions as a board around our strategic roadmap, and we've been having some discussions at board and at Council of Governors around the future statutory role of governors following the release of direction of travel from the department. So those are just a few of the highlights. Does anybody have any questions or queries or observations for the Chair's report? No, thank you. If we can note that then and move on to the Chief Exec's report. Before we start on that, Michelle, I just wondered whether it was just worth dealing with the policies for ratification first, just to get that out of the way, as it were, before we go into the meat of the report. We've got 3 policies to ratify, which have been through the appropriate governance processes, and they're highlighted on the first page of your report, policies for approval. So we've got the leave policy, redeployment and accommodation policy. The main changes are summarised there. The policies have been available for us to have a look at. Does anybody have any questions, first of all, on those policies before we move to ratify them? No questions and comment. Are we content then to ratify those 3 policies, leave, redeployment and accommodation? Yeah, thank you. And thanks for all the work that's been put in on those. So I know some of them are quite complex to review. And secondly, Michelle, I wonder if I can just clarify, we've got ratification of associate hospital manager reappointments. Do we have the names there, Kwame, for those people? Could you just give us those?
Yes, we do. It's buried in 5.4. We have Amy Dibbs. Amy has gone through the process interview, and the name is in the board papers, and the request is for board to ratify Amy for an appointment for 3 years as an approved hospital manager with 6 months probation. Yeah.
So that is a new appointment, isn't it? Rather than a reappointment. So are we content to approve the appointment of Amy Dibb as Associate Hospital Manager? Yes, thank you very much for that. Okay, thanks for those bits of process that we need to attend to. Michelle, can I just hand over to you to draw out the highlights for your report? Thank you.
Thanks, Chair. Good way to do it, by the way, because we always end up coming back, so that's helpful. I was going to mention both of those. I'm going to start with, I think, remiss of me not to mention, obviously, the Malton critical incident that we had. I know that I kept all the board up to date with the process as that was happening, but I think just to go on further record as we will do, it is included in lots of the directors' reports anyway. Just a sincere thanks to every member of staff there who operated the evacuation procedures with absolute perfection, and certainly thanks to obviously the fire service, etc., because it could have been a complete and utter disaster if it had been windy because of the proximity of our of Malton and the actual building that was completely destroyed. So the staff reacted quickly, all the emergency processes worked, the evacuation went initially into the school, and we have thanked the school who were excellent in relationship to our needs and supporting us. And then we did manage to decant all the patients and move them and transfer them to Bridlington altogether, which was great, rather than being dispersed and separated, etc. And we managed obviously the staff transfer and the onboarding of the staff exceptionally well. I actually went up to visit, and the patients were really complimentary of the staff and said that the staff was so calm. It made them feel very calm. And considering we had a 101-year-old person in there as well, it was really quite difficult. So the staff have obviously received some ongoing psychological support, and that will continue as they feel fit. We've done all the work that we needed to in relationship to making the current facility more safe. We've only got half of it because there are some evacuation issues that are fine with half of the ward. It's just the current, because of the proximity to where the actual fire was. So Pete's team are working closely with York, because obviously we don't own the premise, which makes it more complicated. So we've got currently half of what we're operating on, half a capacity there, which at the moment is okay. But obviously we can't sustain that going forward for a long time. So so everything is okay, they're settled back, they're working through things, and obviously we're giving them constant support, but I'm sure we'll note it. The fire cause we're still working through that with the fire service, but we have checked out some of the ongoing outcomes of that, and we'll pick that up maybe a bit later. So that's the Morton piece, but it is, as I say, throughout the director's report. I would like to commend everybody also. I'm sure the board have noted at the beginning of the report, the CQC report onto our crisis and the place of safety. If you remember, we had 2 visits. We've had a few visits, but we had 2 visits, one to crisis and place of safety and one to the CMHT. We're still awaiting the CMHT report. That has not come through yet. Maybe pick up a little bit of that later in the quality report in part 2. But from a crisis and place of safety, we've got that report now, and it is good for the service. Obviously, there are continuing improvements that we need to make, but a good overall rating is great, and I thank Sarah and others, and certainly all the staff involved in relationship to that. So we'll work through the positive areas and make sure they're celebrated, and we'll also work through the areas that we need to develop. I've put a little bit of a resume in about Walk This Way, because I thought that was useful for the board, because we do mention it quite a lot. And one of the things we wanted to do was encourage people who weren't as active as others, so you can just see that. I have to mention this, but I'm going to have to take a big intake of breath because it's a long title. We have changed the Director of Finance's title to really mirror what he is currently doing. So as from today, a couple of days ago, Pete's title is Executive Director of Finance, Resource, Estates and Digital. I think I've got that correct, Pete. I'm sure you'll correct me if not, and that just specifies obviously the emphasis on digital, but also our other service areas as well. One of the important things in the report, and I won't dwell on it now because it's just beginning to develop, is the partnership group with the chief executive officers. One of the things, as you know, I've been working through with the collaboratives is trying to bring them all closer together so we don't operate in silos. And I think it's with the changes that are happening at the ICB and then move away from collaboratives, it was an ideal time to look at how we look at the patch across the system from a provider point of view, because every time we meet, we've got commissioners in the room. That's no disrespect to commissioners, we need that, but we also need some quality time discussing provider issues. So Lynn and I have had a lot of conversation, and we set up a bit of a partnership group, and there's a bit more detail in the report. One of the things that is going to look at is how we work closely together for service delivery. And there are a few areas that we're looking at, occupational therapy, for example, occupational health, for example, and we're going to lead that piece of work. So it will develop over time, but I think it's exceptionally positive. It's a group made up of just the chief executive officers at this stage of the NHS providers. And then we'll probably have some subgroups of the chief officers and the exec directors in relationship to that going forward. So that will develop, but we don't want to develop a massive bureaucracy or a massive set of other meetings either. We want to keep it fairly succinct. Lots of things are changing, as you know, in relationship to Parliament. We've now got another Secretary of State, Yvette Cooper. We haven't had any feedback from the office yet as to mode of travel. We are continuing to feel it with the same direction. Obviously, the Act's going through Parliament at the moment. That had been signed off before it went into the Houses. But what is important for us is that Dame Johnson, who is one of our local MPs, is now the Health and Social Care Minister. So I have reached out to them. We've got a good relationship with Dana in her office, just to see if there's any further support that we can offer there. I think Caroline in the report mentioned the 2 VIP visits that we had from the NHS Alliance and from the ICB. They went really well, so thank everybody that contributed, including the non-exec directors. I'll finish quickly, but just the stretch targets are important to note in the report. These are 3 that we've been developing as a chief exec group on the back of a challenge that came from Jim Mackey in relationship to how is the NHS mental health service going to frame itself going forward. We've got the North, we've got obviously a lot of other targets, they're in our performance report, but he wanted 2 or 3 pulling out. So we've pulled out 3. There has been a slight addition of one that we're not quite sure where it's come from in relationship to the staff survey, but the 3 main ones are the eliminating inappropriate and out of area placements, the reduction of 12-hour breaches for people especially known to service, and children and young people services, a reduction of 50% if 50% in the current numbers waiting above 4 weeks. These will not be monitored at the moment by the NHS themselves. They'll be monitored by the ICB, and I've been asked by Sam Allen, who's our regional director, just to do some work about how we can do that across all the region. So we'll keep you informed of that. And then there is lots of work in there in relation to the directors updates, lots of service updates. Obviously, we're working through the FLEE programme that will start in October. Lots of things about our medical education awards. There's a substantial digital update. There's a little bit about deprivation of liberties, because obviously there's a new judgment that's come through that we're working through the complexities of that at the moment, and I thank Kwame and others for that. But really interesting to note that we are first, organisation first, and we like to be first out of 38 for the urgent community response times, which is brilliant news. So I thank everybody for that. So there's lots in the report. I will pause there, ask my colleagues if they want to say anything. Claire, I usually just come over to Lynn at this point just to see if there's any headlines. There may not be, that's absolutely fine, but obviously there's a substantive report. If there's any headlines from you, and I'll pass over. Thank you, back to Chair. Thank you.
Thanks very much, Michelle. Claire, do you want to come in and just anything you'd like to add?
Yeah, I think it's just a case of drawing out the fact that the winter planning process is underway this year, and it's a case of the board will get to see that at the next sitting, I think, in terms of our draft version has been produced, and we've very much done that in collaboration with the system as a whole and fed back in and fed in what we learned from last year. And then from a service planning perspective, we've just embarking on the service planning round, which is very much an integrated approach of making sure that we take all the factors across the system and broaden that and feed into our services. And that collaboration that we do internally is embarking. So the annual operational plans have commenced on that front. I think in terms of the report, there's some other interesting updates, but I think they're the 2 key headlines that I'd pull out.
Thanks, Claire. Yep, thanks ever so much, Michelle. As usual, absolutely packed report from all the yourself and all the directors. Very informative, very detailed, and really just shows the massive range of work that the departments are doing at the moment. So thanks for all that work, and please pass on our thanks to all your teams. Before I move to Andy, any of the other exec directors want to highlight any parts of your reports? Kwame?
I'd like to bring to the attention of the board in terms of the Supreme Court judgment 2026 on deprivation of liberty, which is a massive shift from where deprivation of liberty laws were. And it will have an implication of how we assess patients who are subject to deprivation of liberty. To also have an implication on our training. And we have presented a briefing paper to EMT, and it's also gone into the inside report to Mental Health Legislation Committee. In the processes, we're giving interim guidance to all our services to make sure that they follow the law, because this law came in and it went into immediate effect. We're still hoping that NHS England will give more guidance on us in terms of code of practice. But we are working very hard to make sure that we continue to comply with the law, and our training would reflect that as well. Thank you.
Thanks for highlighting that, Kwame. And I know it's something that Mental Health Ledge team are alive to. And indeed, on Monday, I had a meeting with our safeguarding lead for the trust as well, looking at some of the work that they're doing around implementing this. So we're not waiting for the guidance, we're getting ahead of this. It's something that's really important for us, although a relatively small number of patients that we look at. but very wide implications for local authorities, and the challenges in terms of resources and getting this right for local authorities is going to be a big theme. But it's something that we as a board do need to understand, and I think perhaps something we need to come back to, just to assure ourselves that the processes are getting in place and getting embedded, and that the training is happening. So thanks for highlighting that, Kwame. Any of the other non-exec exec directors? Sorry, no. Okay, very good. Andy.
Thanks, Chair. It's reflective of an absolutely huge amount of work going on by the exec team, and a great report. Again, this might just be me being new to the situation, but I was interested on the learning from security incidents on page 17, Michelle. Would it be possible to get some context for that? Because the comment is talking about them going up and saying perhaps it was due to improving in reporting and so forth. Is there any data anywhere that you could signpost me to, or perhaps if you could let us have offline, that shows the trend for this over time, just so we can see whether there is sort of an underlying increase, or whether it is something that we need to, and whether it's something we need to worry about?
Okay, thank you. I'll pass over to Sarah, but it is, when we learn from incidents, what we want to see basically, and is high levels of reporting, lots and lots and lots, and we want an increase of reporting across all our areas. And you may think, well, why is that? But we want them at really low level, if at all, no harm. Actually, almost near, well, the best thing is near misses, because that reflects a reporting culture and a safety culture, but it also reflects this absent, the opposite of a close culture, where people keep things to themselves, don't report them, don't want any interference. So what we want to see is that open nature of reporting, lower risk, if no harm, near misses within the system. So we want to see that increase. But what we do want to do is, well, we do have them, even those that we still want to learn from them, so we want them reported, but we still want to learn from what happened and why it was near and near miss and all that type of thing. And they go through the various governance structures into various data analysis. We try and triangulate that as much as we can with staffing, etc., etc. And then finally through the quality committee, up through the quality committee for that assurance, via the exec team into the board. So that's basically it. If there are any triggers or anything that we think we need to pick up, then we'll do that through that governance route. And there are some times that we've done that, we've demonstrated that as well. But it's a good question. Sarah, do you want to add anything on that?
Yeah, thanks, Michelle. I think you said security, didn't you, Andy? So if it's
sorry, I thought you said safety. I'm looking at page 17 and
you said
sorry,
security.
It's the same thing, isn't it? Exactly.
Yeah, so the same principles apply. Obviously, security sits with Pete, so I'll bring him in if I say anything that's wrong. But it is basically, as Michelle's alluded to. But what we do is we kind of produce two. We have a patient safety report, and then we have a non-clinical safety report. And that non-clinical safety report looks at all incidents, security, health and safety, and that. And then I produce the patient safety incident report. And then what Pete and I do is then we bring those sort of two reports together. So we look at everything that's sort of clinical and non-clinical, and we take that sort of through EMT. So again, that triangulation of data, that looking at trends and themes is something that we continue to do. The detail around the drive in why we've seen an increase, again, it is a really positive thing, but that particular detail I'd pass to Pete, if that's okay. Thank you.
Sorry, Andy, I picked up page 17 now. We want on page 17, but it's exactly the same process that I mentioned. So it's just from a non-clinical point of view. But Pete, do you want to add anything?
Sarah's covered it really well. It's actually the ops security team in the Humber Centre reporting that's gone up, Michelle, and I suspect it's, you read the report, it's identification of contraband, the usual things you would expect in a forensic unit. But should any themes arise from that, the process Sarah's described is how we would then take appropriate action.
Thanks, Pete. Claire, was it on that issue you wanted to come in? Oh, you're on mute.
Sorry. Yes, it is. It is the operational team. And I think in terms of, obviously, Sarah's described a process that followed, but in terms of the report, it's more of a celebration of the fact that they have got an improved reporting culture. So it's a case if we can look at what those incidents are and how we better tackle them. So I think everybody's captured that point. But yeah, it's the ops team.
Thanks. Thanks so much for that. Phil.
Yeah, there's been a report this week about the persisting issues of mixed-sex accommodation in the NHS. And I know we're in the process and finishing off planning to move our female patients out of PQ into an HDU in Town Court. I just wondered whether that had happened yet, because obviously it's an example of us trying to solve a potential issue there and provide better services for our significantly ill female patients.
Yeah, shall I bring Peter? He's got his hand up, because obviously with the Director of Estates, he can give you a bit of an update on that. Pete?
So it's not happened yet, Phil. The works are in progress. So I was actually on site earlier last week. Time goes beyond me, doesn't it? So I was actually on site last week, and it's a 2-phase project. So the first phase of work is the refurbishment of the beach ward with 3 bedrooms. That will allow us to vacate the Lilac Walk. So the LD patients from Lilac will step into beach, and then Lilac will be refurbished to create 6 female HDU bedrooms. So we expect it to be about, the late autumn time for that work to complete.
Okay, thanks. It obviously reported it had down as July for completion.
Yeah, we had some supply chain issues, as we always do on doors and windows, unfortunately.
Thank you. Thanks, Pete. Thanks for the question, Phil. Kwame.
Yeah, just to add that obviously moving into a female HDU would definitely help, and it will help in our out of area for females going out of area as well, expansion of PQ. But currently where we have wards like PQ, where there's a mixed ward, we follow every process which is laid down, i.e. the female side will be completely separate to the female side, and the males are not allowed to go to the female side. In terms of a lounge area, we make sure they have female area, and no male is allowed to cross the female area to use toilet facility as an example. We did also update our transgender policy when we had an initial Supreme Court judgment. So we still can improve to make sure that we get new facilities like the PQ. But currently, most of all our mixed wards follow the nationally set up standard to make sure the females are safeguarded.
Thanks, Kwame. That's really helpful, because the report highlights some issues that you've highlighted that were happening in other parts of the country. So that's good reassurance. Yeah, thanks.
Thank you. Sarah.
Kwame's covered everything that I was probably going to say, but just one final comment. So we have to submit data, Phil, on if we have any mixed sex accommodation breaches. So just so you're aware, as an organisation, we don't have mixed sex accommodation breaches. So there is that assurance route from a data perspective where we have to upload as well. Thank you.
Thanks, Sarah. Thanks, everyone. I'm going to draw the Chief Exec's report to a close unless Michelle wants to add anything to what's been said already.
Just draw people's attention to the communications update and the Health Stars update, as I normally do, Chair, but thank you. No, it's good. Thank you to my colleagues.
Thank you very much for that. And I'll just finish by congratulating you, Michelle, on your Chief Exec's challenge this year, raising money for Health Stars. Very well done. I know it was quite grueling, but we're all really appreciative of what you've done, and I'm sure the recipients will be as well. So thank you for that.
Yeah, and thanks staff for their comments and their challenges.
So let's just move on to the policy and publications and policy highlights. I really like this report, particularly the focus on how these myriad of national policies and procedures and goodness knows what affect the trust, which enables us to really focus on what we need to focus on, which is how it affects the organisation and its patients. Unless there is anything anybody wants to highlight, I think we'll note this. Is there anything of burning interest that anybody would like to highlight on this report? No. Thank you very much. We'll note that report, really good report. Thank you very much. And we'll move on then to the Freedom to Speak Up annual report. I know Alison is here, I can see her.
Morning, staff.
Morning.
Morning, everybody.
You're most welcome. I'll let you introduce.
Thank you. Before I start, Michelle, did you want to say anything before I go through the report?
No, just obviously it's here to approve. I thank Alison and the ambassadors for all their work. It's great that we're getting a growing number of ambassadors in relationship to the organisation, and the fact that we've had some positive assurance reports from audit, etc. But I will pass over to Alison for the detail on the report. Thank you.
Thank you. Thank you. So this is the annual Guardians report for Speak Up, and you'll see that it's been a very busy year for Speak Up, which is really good. And I think hopefully you'll see how much work has been undertaken working with all of the teams across the trust to continue to embed speaking up and raising concerns. So I'll just pick out the key points from the report. Colleagues will notice that the National Guardians Office closed at the end of June. This is as a result of the changes within NHS England and more of the responsibility for Speak Up oversight moving to the Integrated Care Board. So we are working closely with our ICB about the changes that will happen as a result of that. And there is now an increased continued focus from a CQC perspective as part of their key lines of inquiry. So we're doing more work on that. I'm pleased to share that the completion rate of the level 1 training for Speak Up, we had 97.42 compliance rate, which is really good. It is part of our suite of mandatory training for all staff, and all staff have a presentation as part of the trust induction as they come into the organisation. You'll see that we've had an increase in the number of concerns. So it's gone up an increase of 20 from the previous year. So 51 concerns raised through Speak Up. What it is important to know, I think, is that if more than one staff member raises the same concern, that's still counted as another concern. And we have had a couple of those, but there still is a definite increase on the number of people contacting Speak Up with concerns. The types of concerns are listed within the report, and we have seen a reduction as part of the Report It campaign that was run through our Trust's HR team, where we're getting contacted less for people's concerns about their own terms and conditions, or where they might have something around grievance or something to do with their own situation. So we do still work really closely with HR, but I think that campaign has seen a reduction. A key focus of Speak Up is about outcomes and learning. So there's some examples in the report where we've put, we've had concerns raised in the outcomes, and there's a short case study, and we want to do more of that as we increase our comms across the trust. You'll see that we've had a really full ambassador programme, so we're continuing to try and recruit ambassadors. We're seeing that staff are speaking to the ambassadors, and what we've tried to do is a bit of a development programme for the ambassadors as well, which has been really well received. And Michelle met with the ambassadors last week, and I think that's really helpful to continue to reinforce the importance of Speak Up and the commitment from the board. The feedback that we received from people raising concerns has been really positive. So there's some really nice quotes and feedback there from staff. And we do continue to focus on what the feedback is telling us, but also who's raising concern and where we might have some barriers to that. So this year I've been to all of the staff networks to raise the profile of Speak Up, but also to try to recruit more ambassadors. The staff survey results, there was a slight drop in the number of people within our 2 key questions in the staff survey. So we're looking very closely at the staff survey results and highlighting and focusing on the areas where there hasn't been such a good response, so that we can go into those teams with the ambassadors to raise the profile of Speak Up and to kind of squash anything or give further learning to those people. The programme of work from last year, our priorities, there's an update in the report and the outline of our priorities for our work plan for 26-27. So I'm happy to take any questions, Steph, and I'd ask the board to approve the report, but also confirm that they support the priorities for this year. Thank you.
Thanks very much for the presentation, Alison, really appreciated. I wondered, Carrie, if I could just check with you, has this report been to people in OD committee as yet, and as Guardian, as non-exec representative, as it were, is there anything that you have to observe about the report?
I don't think it'll have gone to people at OD yet, will it, Alison? Because
It's going in
August.
the week after next, and it's been through the Trust's executive management team as well.
Yeah,
Brilliant.
Yeah,
That's
the last people in OD was a short version to sign off for specific sort of policies, papers. So yeah, no, so but it's due in another week. Observations. I mean, it's a comprehensive report. It shows that we've got, through internal audit, significant assurance. It's open about where there are challenges and trying to engage more in terms of ambassadors. So I think it's a really positive. It's a positive report in terms of Humble's approach to freedom to speak up. I think, it sets out some of the issues that have been raised, and I'm starting as the lead or champion for freedom to speak up as a NED. I'm starting to meet with Alison 6 weekly, I think, something like that, isn't it? 6 weekly, and with Michelle and Alison at the sort of quarterly, I think it is, meetings. So hopefully that will help me to think about ways that as a NED I can start to raise the profile of freedom to speak up on my travels around the organisation. Because when you're doing visits, it's easy to forget all the different things you need to kind of raise and ask staff about. So freedom to speak up should be front and centre for me of that. So that's something I'll try and do.
Thanks, Carrie. That's really helpful. Thanks ever so much for that. Pete.
Thanks, Steph. Really good report, Alison. I think it's just more for the board's awareness more than anything, Steph, that raising concerns does form part of the National Oversight Framework. So our staff survey score of 6.94 put us 11th out of the 61 in our comparator group. So we're upper quartile currently, but I think it's important we keep that focus, because obviously the Oversight Framework is of critical importance in terms of our strategic roadmap.
Thanks, Pete. Alison, is that built into the priorities for the coming year?
It's not explicit in the report, but we can make sure that it's added to the priorities. And thanks for raising it, Pete.
Yeah, that makes sense. Thank you. Kath.
Thanks, Chair. Thanks, Alison. Once again, echo Carrie's comments. Really good report. Lots of good information in there, especially for a relatively new non-exec. I guess the bit for me, I was just going to sort of provide a bit of feedback on was, for me, freedom to speak up is about, the outcomes and the impacts both on individuals and teams where they've been raised. And I think there was a really good example at the bottom of page 3 where you've kind of closed that loop for the board and given us, this is what happened, this is what we've done, this is what we investigated, and this is what we've done as a result. And I was trying to see the same in the other areas which you've raised, and it probably didn't quite close the loop for me, if I'm honest. So the outcome of so the second example at the top of page 4, when we talk about a 6 month deep dive review of incidents, staffing, sickness and vacancies, sounds like a really positive piece of work. But I guess for me it was the so what. So what did that tell us? And what did it change or impact as a result? And that's the same for the other ones. And I just think especially from a non-exec perspective, thinking about talking to, CQC interviews, for instance, around being able to tell that really positive story about some of the work and how that's impacted on what we have done as a result. So I was hoping from a reiteration as it goes through. I know you come to board every 6 months, maybe just taking that on board around just how we close that loop and what we can see as a board of the impacts of those cases.
Yeah, no, that's a good point. Kath, just before Michelle comes in as well, one of the things that we've also started doing, which is in the report, which I should have mentioned, is we now have a case review meeting with colleagues from HR, Ops and Quality, and I think that is further embedding our triangulation really of the concerns that are raised. And I don't know, Claire, I work really closely with Claire from a Speak Up perspective, so I don't know, Claire, if there's anything you want to add from an operational perspective as well about how our processes work.
Yeah, I think in terms of the examples exist, Kath, in terms of the so what and the outcome, I think it's a case of obviously we can incorporate that. But I think that triangulation that Alison makes reference to is really key, so that we're not looking at the Freedom to Speak Up in isolation and we're working across the organisation to see how it correlates with other issues. So, but I think it works really well, and I think the fact that the numbers are increasing is a testament to the amount of communication that's gone out there and people feel comfortable using the service.
Thank you. Thanks, Chair.
Thank you. Michelle.
Yeah, no, it was a couple of things that picked up from the conversation, which I think has been really helpful. I do think we do need to put more in about outcome, and it's a really good point, Kath, because we do keep them, because we do want to. So I think it's about demonstrating them. So I think that's a really, really good point. I think that triangulation is also vital, and it's not just across Food Speak Up. We've already raised it both for security and for patient safety, which we had a conversation on just a while ago. So I do think for me that real push on triangulating the data that we've got, because as standalone reports, they're interesting, but they're telling us something, but they're not telling us the full picture. So we're doing more and more of that. And it was just a comment really for when NEDs do go out. I mean, I know that we've created some, and I think it's on that list. If it's not, it remiss of me to miss it out. But just to remember when you go on your visits to mention Feed Speak Up, wherever that is, not just in the clinical areas, also in the corporate areas as well. It's just as important there. Just to say, are they aware of the service? Do they know who it is? Are they interested in becoming ambassadors? Because for me, we want as many ambassadors as we can across the organisation, being such a dispersed organisation. So if you can just remember, and Andy, again, this comes back to a bit more about that culture and that moving away from the closed culture. We want more reports from Feed Speak Up, the lower threshold, as it were, but we want more reporting. I think that's really positive. So, but no, thank you, Chair. That was just it.
Thank you. That's great. I'm going to draw that discussion to a close now. With the caveat on the looking at the national performance issues around the key priorities for next year, are we content to approve the report and the priorities for next year? Yep, seeing nods, thumbs up. Excellent, so that's approved. And obviously we'll note the comments that have been made regarding outcomes and triangulation for future reports, because that would really sort of raise the bar of the reporting. Thanks, Alison. Thanks so much for your input, and thank the team as well.
Thank you. Thank you very
everything that
much,
do.
everyone. Thanks, Sarah.
Thank
Thanks.
you.
Bye-bye.
Okay, so we're going to move on now to digital. So we've got two reports, digital governance and digital enabling strategy. I note that Lee Rickles has joined us. Morning, Lee, you're welcome.
Good morning,
to
thank
see
you, everybody.
So I don't know who's going to present this. Are you going to lead off, Pete, on these reports?
Yeah.
Yeah,
If I could,
lovely.
please, Steph.
Thank you.
So
Yeah.
if I take the digital governance review first, so following the board development session we had on digital, the Trust commissioned a review of digital governance with our Audit Yorkshire colleagues, the outcome of which is attached today. You know, we have seen this at Be Digital Group, we have seen this at Exec Management Team, and we also saw it at the Finance Committee this month. You know, we've attached at Appendix B the progress we've made against those recommendations we signed off with Audit Yorkshire. Some of that does include the digital plan and enabling strategy coming to the board today. You know, in response to the digital review, we did put together some revised terms of reference for the Finance Committee, which, and I know we've touched on this before in board, we are now proposing, we call it the Finance, Productivity and Digital Committee, which kind of reflects the range of discussion we're now having at that committee. So it kind of reflects the three parts. You know, Finance Committee, well, Finance, Productivity and Digital Committee, if that's what I'll call it now, did support those revised terms of reference last week, so they're here today for approval. I have noticed I will have to change my job title to the amended job title in those terms of reference, but I can pick that up with Stella if the board approve them today. I think I'll stop there, Steph, and just take any questions.
Thanks, Pete. Any questions or comments? Keith?
Thanks, Chair. Well, Pete knows I was going to bring this up in my assurance report, Steph, but we haven't. Obviously, this has come before that effectively. But we did see those both those papers at committee. I think whilst we approved them to go forward, we kind of, as a committee, reserved the right to study them a bit longer because they came in quite short notice in terms of the pack. And I'd like the ability to reserve comment, if that makes sense, on some of them. I think they're fit for purpose, but I think there are some areas that we might want to look at expanding. So I was going to say from my report that we were kind of partially assured, with a subject to come back to Lee and query if we felt there was a further questions to be raised, Steph. And it was simply that we just didn't have them for long enough to, they're both quite big, comprehensive documents to be able to fully go through them. Pete, I don't think that's anything we didn't say at committee, is it, just to reflect that?
I think we said we keep it under review, the committee, as we always do, Keith, don't we? I mean, it's evolved over the last 18 months with productivity and now digital focus. And part of our annual effectiveness review would pick that up.
Yeah, I just wanted to reflect that, Steph, so it doesn't go unmentioned, if that makes sense.
Yeah, that's absolutely fine. And obviously with documents of this kind, it's good practice to keep them under review anyway. And I think absolutely right that coming back to this and having a little bit more time to look at some of the issues is really important. So I think we should note that. But equally, I think we're probably in a position where we can recognise the work so far and where we're at. And Kath, can I just ask, just from an audit committee point of view, we haven't mentioned audit committee yet, and I don't recall at audit committee that we've had these papers as yet either.
No, this hasn't come through. This wasn't ready in time, I don't think, for the audit committee. I know it was planned to come to finance committee anyway, because it's more discussion about the recommendations. I don't know if it's scheduled to come through because we got an audit committee. It'll be middle of September now, Pete, won't it?
I mean, we didn't, when we discussed it with Audit Yorkshire, Kath, because this was a governance review as opposed to an internal audit of system and control, we suggested it went straight to the finance committee because that was the committee that's got the responsibility for digital. More than happy for it to come to audit committee if as audit chair you would like to see it. But that was a conversation myself and Michelle had with the auditors when we went through the initial governance review and then took it through exec.
I think for me it'd be more about just putting the recommendations into the pot of closing recommendations, really, because I'm happy. I was obviously present for the discussion at finance committee and heard what we had to say about it. So I think it's just making sure that those can go into that overall pot of audit recommendations.
Can I come in there, because there are actually no audit recommendations. If you remember, I mean, they are in the note because it's been done by Audit Yorkshire. If you remember, I was anxious about the governance structure from a digital perspective. That's where it started when we had some sessions with NHSP, I think at the time. We had some of those open conversations with them about the digital contribution and how we were monitoring digital across the organisation. And I was a bit anxious and a bit concerned about what our governance structure was like and the reporting into various committees and bodies, mainly the exec management team, and also how do we do that from a structural point of view, from an assurance through a committee or through the board. So we said, well, we'll do a bit of a governance review. So we could have put it out to tender. But what we did, I think we did a sort of mini procurement, but Audit Yorkshire ended up doing it for us. It's been done through that route. So we could bring it into the audit committee, but I wouldn't want it added to the audit report that Ian does, because they're technically not part of that audit report that then feeds into our overall assurance process at the end of the year from Audit Yorkshire, if that makes sense, Kath. But we can have it as a separate entity, that's fine. But the governing body for the report actually is the finance committee. Which is, I mean, actually it's the exec team because they sponsored it, to be fair. But you know, we've transmitted that to the assurance committee, which is the finance committee. If that makes sense, does that sort of make sense now? Because it's more a separate review. It just happened to be Audit Yorkshire that did it.
Thanks. Thanks for clarifying all that, Pete and Michelle. That does make sense. That absolutely makes sense. And obviously that clarifies things in my mind. I just see internal audit on there and think in that manner, but I'd obviously not been privy to the history, if you like, of this. So that might have been helpful just to explain at the top of the document, but that's absolutely fine. So I'm just going to take a couple more comments and then we'll draw this particular document to a close. So Phil.
Yeah, it's good to see that the trust has responded quickly to recommendations. I just wondered if we could get a little bit more insight into the one where it says there remains insufficient clarity on which digital decisions should be escalated to senior committees. So are we also working on how and what goes up to finance committee?
for me, Phil, that forms part. So we have the Be Digital group. We meet. That provides an assurance report into EMT, who are the decision-making body. EMT will then provide assurance into Finance, Productivity and Digital Committee as appropriate, and that's the conversation we would have at exec as part of that conversation. And then at Finance, Digital and Finance, Productivity and Digital, we get it the right way around. We would then have the conversation about, and as we have done this time, there's a paper on part 2 today where we saw a paper that we thought it would be right helpful for the board to have full coverage of a paper rather than a chair's assurance report. So that's quite a long-winded answer, but I think it's, it's embedding. I think it's learning as we go along, and obviously we'll also pick that up as part of the annual assurance review.
Okay, thank you.
Thanks, thanks, Pete. Andy.
Thanks, Chair. Yeah, I just wanted to echo Keith's comments, really. I think that it's a big topic, it's a big paper, and I think that the improvements that have been made to the governance are going to be very effective for the trust. And it's also good to see that the trust has responded in this way. It feels to me as though this is a matter that will more than likely evolve quite a bit over time. And I think that the fact that the Finance Committee has said that it will keep a close eye on this, I think is reassuring. So I think that as a holding position, it makes perfect sense to me. I think as we go through time, the issue may well evolve, not least because of how dynamic the matters around AI are in the outside world more generally. So I think the Finance Committee, got the new name, but anyway, you know what I mean. We'll keep a close eye on this. I think for the minutes, it's just worth saying that we are observing that this is likely to evolve over the course of the next 6 to 12 months.
Good.
Yep, thank you. That's a helpful way of putting it, Andy. Thank you. Thank you. So in terms of the actual report then, we're content to accept the report, note the progress that's already been made, note the fact that it will evolve over the next period, and that from a governance point of view, our Finance, Productivity and Digital Committee will maintain an oversight over developments in this area in line with the governance framework that's been set. So are we happy to approve that sort of minuting of the situation? Brilliant. And then can we formally approve the terms of reference for the new Finance, Productivity and Digital Committee title, and then all the things that go within that in the documents? Yeah, happy to approve that. Brilliant. Excellent. Thank you very much. Shall we move on then to the digital plan and enabling strategy? Pete.
Lovely. Thanks, Steph. If I can tee it up and then I will hand over to Lee. So these papers are actually brought today for board approval, under the decisions box, and they have been through a robust governance process, including Be Digital, Digital Delivery Group, EMT, ODG, Finance Committee. Take on board Keith's points, but any plan, in a changing environment is often continually under review, but they are brought today for approval, and then we'll monitor progress against them. I think the strategy and the plan for me is ultimately about making it easier for patients and service users to access our services and care, communicate with services and play a more active role in managing their own care and health and well-being. The plan and the plan and strategy should enable patients to experience more convenient digital access to appointments, records, information, improve communication with teams, and ultimately promote the use of virtual or remote care options where they're appropriate. And we know that's a changing space throughout. Not forgetting our staff, strategy aims to reduce administrative burden for our staff, making it easier for clinicians to spend more time with our patients and releasing time to care. So before I hand over to Lee, I do just want to thank Lee for all his leadership and pulling these documents together. As I said, they have been through a lot of governance into a lot of the groups, and Lee has taken on board all the comments from them before they presented here today. So I'm going to stop there and just hand over to Lee to go through some of the headlines, and then we can move to questions. So Lee.
Yeah, thank you, Pete, and thank you, board. It's a real pleasure to be here to cover these two quite significant documents, as Analog to Digital is one of the 3 key pillars of the 10-year plan. As Pete says, it's a golden thread, but it's really an enabling capability for our enabling strategy to support our organisational strategy and strategic goals, and also our digital plan, which is directly linked into the service plans and there's a bit of a lag between the service planning and digital plan because it's completely developed in conjunction with all the teams within the organisation, but also reflects the needs of them teams. And also there's a little bit of work we need to do on setting a level of expectation and reality of what can and can't be done. And I think that comes out, if you could just bear with me, there's a clear linkage and it comes out on the presentation that Justine did at the beginning of the board, where a lot of the reason we can actually assess waiting lists, the types of referral, the risk to patients is because of the level of information we have with System 1, albeit data quality still can improve. The investment in Connect come directly from digital. That's something that I'm very proud of myself, and it's an excellent piece of work, which is really making an impactful change to the patients we've got. The Do It Profiler, which Justine didn't touch, but makes a massive difference to our neurodiverse adults and children's waiting list management and risk assessment right at the point that the referrals come in, so we can make sure we are providing the appropriate care, or we can direct or use digital tools to support them. One other thing that was quite interesting on Justine's at the end of Justine's presentation is the issue around reporting. We have some extremely capable reporting tools and analytical tools. We use Power BI, and that's going to be moving to a new version soon, but also Databricks, which is an industry standard for data reporting and repository. Not going to go into technical issues. The key bit there is very capable tools, industry standard, way ahead of what most tools are in the NHS. But we are more than aware that that's a transformation and a training and support and development issue. And we're completely aware with BI using business intelligence for the bettering of our patient experience, the outcomes, and our staff experience, using them business intelligence tools, but also the use and application of AI in a safe and secure way are key areas we need to develop. These are items that are in the plan. The training development is being done in conjunction with people in OD. Most of these actions are in conjunction with other teams. It's not a digital team locked away somewhere. In most cases, if not exclusively, it is done that way. There are the two documents. The enabling strategy takes us forward 4 years, and it is based on the What Good Looks Like framework, which is the method that NHS England assess all NHS and non-NHS contract bodies, but do contract to the NHS for their digital maturity. So that's why that framework's in place. On the areas we score low, we have got significant investment. One is the patient access. So we are leading nationally on System 1 and the integration of Wayfinder. Wayfinder is the ability of patients to book and schedule appointments, receive information, receive messages. Just to clarify, we already do send a lot of the messaging information using AccuRx. This will be moving us forward, and also being able to have that two-way communication digitally with our appropriate workforce. So I have the sections itself are pretty clear. There is a whole focus around equality and inclusion, reasonable adjustment flags, how we're sharing information, how we lead on some of that information sharing with the Yorkshire Member Care Record, which also makes a significant difference on our staff being able to access that information for better decision making and information sharing. We're now linking into the Carers app in East Yorkshire, so that information is now going to start flowing. For instance, all this is detail that is in the underlying groups that report into the Be Digital group, and there are far richer reports in there. The digital plan is very much a top level document for this year. It does have a set of KPIs in there which are focused very much on the plan itself. There are other KPIs that we use for the wider organisations. They're very much focused on the digital plan, and the strategy is taking us forward in the way that the 10-year plan, medium-term plan, commission intentions, and our organisation and team want to move forward. So I'll stop at that point and hand back to Chair for questions.
Thanks very much, Lee. That's really helpful. Good document. Any questions or comments? Bill?
Yeah, I just wondering if you've got any reflection on the digital maturity assessment, which showed a slight decline in 2025, and particularly opportunities for improving care, particularly empowering people, and also well-led, which looks like there's some change in criteria. And how are we going to, it seems a little sort of vague to say by 2030 we're looking to improve it. Are we not going to improve it by next year?
So the annual plan does improve it, Keith. There was a paper that went to EMT that provided a very detailed breakdown of where the improvements are and where they link into the previous annual plan, and it also links into this year's annual plan. I can go into quite a level of detail on every one of them items. Some of it, as you said, Keith, is there was a change in criteria. This year's digital maturity assessment's due to be released in August, because obviously that's the best time to send assessments out during a big holiday season. We will also have other questions come on. Some of the reasons we actually went backwards was it was during our transition between Lorenzo and System 1, and we had to be really honest and be very transparent that we did lose during that transition some capabilities, or we did stop some level of development in Lorenzo, which would have progressed on the digital maturity assessment. This year's digital maturity assessment will show we have made significant improvement, especially around some of our weakest areas, Keith. More than happy on the annual plan if it's a requirement to put some target levels of where we expect to be annually. That would it's just not shown in the plan, but it does exist in the detailed tracking, Keith.
Okay, thank you. Probably outside the meeting.
Let's go to outside.
I'd like to understand, particularly around empowering people, because I see that as a key part of improving patient reported outcome measures and improving how we interact with our patients. But outside the meeting, that'd be
that'd be brilliant to pick that up separately, Keith, or even to do a bit of a deep dive on where we are going on Wayfinder. Because it is we are leading nationally on that one for System 1.
Thank you. Thanks, Phil, for that. That's brilliant. Kwame.
Neil, welcome. Thank you for the hard work, and I know a lot of work has gone into it, and a lot of consultation has gone into this to produce this outcome. The thing that I wanted to reflect is the fact that I leading on health inequality and population health for the trust. I am really excited that has been referenced in the report. Sometimes when you talk about IT and the AVET and everything, we sometimes lose a few people who are not able to access IT and able to access services through those platforms. And we have referenced that in the report, and we're working very closely with the digital team with things like adjustment flag, to make sure that we are able to identify patients who are not able to access digital. Not that we don't want to take them along, but if people need telephone or people need adjustment, we are able to identify that and move forward. I know these type of questions has been asked in a few different forums when we are talking about digital. We are aware of the digital poverty, and we have adjustment flags work going forward to be able to identify people that we can help in the process. Thank you. Back to you, Chair.
Thanks, Kwame. Really good question, one that comes up quite often. I don't know if you have any quick comments about that, Lee.
So for the reasonable adjustment digital flag, we've been paced heavily by NHS England on enacting against the information notice standard, which makes it a legal requirement now to implement. For System 1, we will receive that capability in January 2027, because that's the deadline that NHS England has provided to the GP systems. There's a whole piece of work going on organisations onboarding on that piece of work. There is regular meetings also going on with Department of Health and Social Care concerning social care. And when I'm saying social care, I'm not talking local authority, I'm talking the wider providers of social care, which are generally the people who are the majority of the care provision, of which there is some work going on with the Department of Social Care, which we are very much keyed in. I am very close to this one as I'm the National SRO for Regional Adjustment Digital Flag, and it has been an interesting journey. But finally, we've got NHS England to agree a set of delivery dates for system capability. So that will only enhance, because that will make the life so much easier for our patients and their carers, for adjustments being made and being visible and shared, because in a lot of cases at the moment they are siloed to particular organisations and only known at that point in time, which is not good enough, because it needs to be as real time as possible. The use of the NH app is where I would see that going to in the next financial year, where that can be done directly by their patient or their advocate. There are a few more steps to do that, but that is on the NHS app roadmap as well.
Thanks. That's really helpful. Thanks, Lee. So with those questions and comments, are we content to approve these documents, the digital plan and the digital enabling strategy? Are we content with those? Yep. Superb. Thank you very much. And thanks to the team for all the work on that. I know, and it's been through numerous different groups and discussions, I know, involving all sorts of clinical and non-clinical staff as well. Pete, did you want to just come in?
Brilliant. Thank you for approving it. And just for board's awareness, we will be monitoring progress against the plan enabling strategy at EMT, Be Digital, and obviously Finance, Productivity and Digital Committee. And those updates will come via the assurance report or a separate report if deemed appropriate, Steph.
Yep. Thank you. Really exciting stuff. Thank you. Excellent. Oh, Michelle, hello.
So I know you want to move on, Chair, but it would be remiss of me not to just thank Lee and thank everybody that has contributed to it, because I know it's been a long time in making, but also Keith and the Finance Committee, because I know they've had some involvement as well as it's been developed through the process as well. So I think it's been a team effort. So thank you. I look forward to see where it takes us next.
Thank you very much. That's great. So with that, I'm going to take a short break, back at 11:15, please. Can we just confirm recording is off? Excellent. Well, welcome back to this board meeting of Humber Teaching. We'll carry on with the agenda just now. We're on item 12, learning from deaths. And if I could hand over to Kwame to introduce this item. Thank you.
Thank you, Chair. So this is a report, learning from death and mortality report. A few observations to say that when it comes to learning from death, sometimes comes across a lot of statistics, but behind the statistics is people's loved ones and people that we've cared for, and we cherish their memory quite greatly. And the second point I wanted to make is that we still continue to work with the medical examiner and the coronial process, and we take those responsibility well. Indeed, the last quality committee, I did present the medical examiner report, as well as our policy on how we work with the medical examiner, who has actually been into our trust to talk to us about the processes. And the third point I wanted to make is that we still have live processes which we use to manage incidences. So we have the PSERF process and we have CRMG. So we don't wait for a cumulative report of learning from that. If we have to react about issues which are current, we do that immediately. So this report is to enhance what we already see in the board. So Pete religiously sends a board dashboard on mortality data, which is in the performance report on page agenda number 20. And again, this report has been to quality committee, and our intention is that this report, the 6-monthly update, would come through as board assurance, and indeed Phil, as chair of quality committee, has put it into his board assurance framework. To the report, so we've covered a few areas in the report, and initially started with the data, and then we've gone into areas of the different areas where we look at gender, we look at age, we look at service areas, and have data to analyze. In addition to that, the report includes our relationship with systems, because it's important that we learn from death within our trust, but learning from the system is also important. So we do the LEADER, which is the learning from death for learning disability in ICB level. We are part of the National Northeast Learning from Death group, and we are also part of the ICB Learning from Death group. Again, that gives us a holistic view of how we can learn. I've also made an important conversation around how we involve families into our learning from death, which is really important and is something that we cherish in this organization. We have a working group which looks at learning from death and the themes, and what we do is that we feed back into QPAS, which is our quality patient and safety group, and then that would come through the governance process through EMT and to quality committee. So moving forward, the intention is that these reports would go to quality committee every 6 months, and then would culminate into an annual report, which will come to board with the intention that once board accepts, we have the work with comms to be able to, for transparency's sake, put it into our website, which is something that a guidance from NHS England. So today, I'll take that all the details of the report have been read. Most of the findings, we looking at the data, does not show any consistent concern or causative concerns. We have areas which we're going to focus on, which includes MDT working, how we help patients with physical health, especially mental health, and those are also highlighted in the report. So, Chair, the thing that asks from me to the board is for the board to accept this first iteration of enhancements of our learning from death and mortality report, and also to endorse the fact that when we finally get to an annual report, the board would support the process to publish that. Thank you. Back to you, Chair, and I'll take questions and observations.
Thanks, Kwame. That's really helpful. Yeah, and it's noted that obviously this Stella will need to go onto our work plan, our annual work plan, which is an annual report, and welcome us looking at options for how we best publish this information as well. Really important area for learning for the future and national significance as well. Phil.
Yeah, just to say that it's already been called to committee, as Kwame said, and you know it's really, we wanted to incorporate this into our regular assurance to try to understand how we can improve the life chances of people with severe mental health and learning disabilities particularly. And I'm sure the report will evolve because to some degree there's a lot of, if you like, natural deaths, and we need to be able to look at subcategories to learn to see how we can do things better and differently. And this is an area that the life chances of people in certain categories that we care for are substantially worse than the general population. And so we're hoping that greater scrutiny and focus on this area will help us understand what care, prevention, support we can do differently to improve people's life expectancy and also healthy life expectancy.
Absolutely.
Thank you,
Absolutely.
Phil. I mean, that is exactly what we're doing with, so the ICB mortality group is chaired by Dave Craig, who is a public health. And one of the things we're looking at is looking at health inequality, especially in home, where we have a lot of deprivation, to see how we can link mortality report into health inequality, and where we can be able to find areas in which we can support patients. I mean, some of the things we talked about in the digital, such as reasonable adjustment, means that we can identify these people early and provide enhanced services to be able to support them. Thank you. Kath.
Thanks. Go ahead, Kath.
Yeah, thanks, Kwame. And some of my questions, obviously I've got a bit of experience with the acute trusts format of learning from death, so apologies, I'm trying to apply those in this context. So one of my first questions was just around the data. So I was looking at this and looking at the dashboard, as you rightly pointed out, that's in the performance report. And one of the things I guess that I'm more used to seeing is the comparators and benchmarks that are given nationally on the standard hospital mortality, the SHME and the HSMR. So I did wonder how does that feature in our work to give us that sense of how we're performing against other trusts. It's not the right word, performing, but where we sit, and if there is any areas for concern, I suppose.
Yes, I did. I actually had a whole meeting with the mortality learning from death lead from the acute trust. They do get a national data which comes through. Unfortunately, mental health don't have that data. That is why we have joined the North of England Alliance Group, and we're hoping that with that, we'll be able to build our own data. But this is something that we reflected to nationally. So at some point, as the North of England Learning from Death Alliance, we'll be able to build some data and then do some comparison between trusts or within regions.
No, that's really helpful to know that, Kwame, and I do still, think the data analysis you did in the report, particularly to outline, where the deaths are natural causes and then focus on those that need further investigation, was helpful. And it was just that wider context I was thinking about. So good to hear that you've already raised that as a national issue. Obviously, one of the things, the reasons for doing this is, like you say, for learning. So in your report, it talks about no consistent themes were identified that are indicating that you've got concerns with care quality issues. But then in the key risks, it still mentions about that continued focus on physical health monitoring and escalation, particularly for those with mental illness and learning disabilities. And obviously we know outcomes can be poorer for those patients. So I guess, am I linking those two things inappropriately? How do they fit together?
So the theme, one of the things you want to draw out, is there any causative concerns coming through. So you would always get themes that comes through, and the themes would be learning that we're picking up. And some of those learning that we picked up are the areas which we were going to focus with a small group as well as with the patient safety group. So those are the areas, especially physical health monitoring. Again, these are areas which are known widely and also nationally. But we believe that after our first update, we believe that these are the areas we want to focus on to see whether there's anything that we could do to be able to improve things. We might not see the graph coming down almost immediately because these things take a long time to do, but those are the areas we picked. But we didn't find anything that we could say these are causative to the death of these series of patients.
Okay, that's good to know. And then you've got a planned audit of compliance with the learning from death procedure. Is that sort of clinical audit, and would that go up through into the quality committees Phil was just talking about?
The intention is once we start to get all the data, once we collect a lot of data, we should be able to then subject the data to audit. And that is what our clear intention to do that. So for example, would be for us, as an example, if we pick up a lot of themes and a lot of actions, we want to run an audit to see whether those actions were closed and the loops have been closed successfully and is left to service change.
That's great. That sounds really important. And final, really quick question. Has the Trust got any prevention of future deaths from the coroner Reg 28s that are outstanding?
No.
No. Okay.
We don't have one from the foreign coroner, but we do, like I said before, we do consistently work with the coroner, and we take our responsibility to present cases to the coroner with learning on a regular basis.
Thank you. I think it's just one of those things that, once again, from an acute perspective, it might feel different in for the numbers that are coming through acutes versus mental health. But once again, I think it's something we should be cited on if we haven't got any, and they're closed from historical purposes. So I was just making that inquiry. So thank you for that.
We don't have any Reg 28. The other thing that we do is that when myself and Lisa look at all Reg 28 from neighboring mental health trusts and nationally, and we look at them to see if there's any learning that we can have from any Reg 28 which has been delivered by a coroner, not necessarily within our service, but even in London or Manchester. So we'll do look at them and see if there's anything that we can learn from.
Sounds excellent. Thank you, Kwame.
Thank you very much. Really helpful report, and some really good points there. Really interesting to note the lack of national comparative data again in this area, and it's a theme throughout mental health, isn't it, really? Which hopefully is something we can help as a trust to put right through our contacts and networks in due course. Obviously sometimes the focus tends to be on the unexpected, unnatural deaths, doesn't it? But there is a wider picture here that we need to be really alive to as a trust as well. So that's really interesting to note. So with that, are we happy to note this report? Thank you very much. Thanks, Kwame and the team, for putting it together. Really important work. Thank you.
Thank you.
Let's move on to item 13, which is our multi-professional strategy. Sarah, I think you're going to introduce this one.
Thank you, Chair. So I'm presenting today the multi-professional strategy, which is an enabling strategy to support the delivery of the Trust strategy, and it's here for approval. It's very much grounded in our Trust values of caring, learning, growing, and ultimately the principles of being Humber. The enabling strategy has been developed into a response to increasing complexity across health and social care, including rising demand, workforce challenges, variation in practice, and the need to reduce health inequalities. And what the strategy does is it recognises that our greatest opportunities lie in enabling all professions to work collectively together, but also at the top of their professional registration to improve outcomes, experience and productivity. The strategy has been developed through intensive engagement with staff of all levels, across the professional groups and also service users. And that engagements took place probably now over a period of about 6 months. The strategy, enabling strategy, is framed around 4 strategic promises, those being professional, workforce, care and innovation, and people and community. And within each of those 4 promises, there's a number of I and we statements. So what the patient, the service user wants, and what we commit to do as professions. Within each of those is a call to action, and then there is associated outcome metrics aligned to each of those promises. The strategy also details the governance and monitoring framework associated within it as well. And obviously the next step is for approval, and then we'll move into developing the delivery plan and framework and associated metric monitoring as well. So happy to take any comments or questions.
Thanks, Sarah. Any comments, questions for Sarah? Carrie.
I like this document. I thought it was quite what's the word? Quite uplifting, really. So if I was looking at an organisation thinking, where would I, you know, if I'm a staff nurse, where would I like to work? I thought it was a really good document for kind of setting out ambition and where you might get to or how you might work in that organisation, which I think was quite unique. I've not really seen it in other organisations. So I thought it was quite positive. I really liked some of the patient statements. I think there's one, Sarah, where it talks about just kind of reminding people that not everybody is digitally minded, and that face-to-face relationship is still really, really important. And I thought that was quite good because it is easy to get. I mean, I'm terrible for digital stuff, so I use it all the time, and it is a good reminder, isn't it, to just not forget that some people just aren't as digitally minded. So I welcome the document and thought it read really well and flowed.
Thank you. Thanks, Carrie. If I could just comment on that, please, Chair. I think what is common in lots of organisations is they'll have like a nursing strategy, or they might have an AHP strategy, and they have individual strategies for individual professional groups. And what I really wanted was to bring the power of how the professions work together as a collective team, as opposed to looking at professions in isolation, which I'm hoping will ultimately be the thing that gives us the greatest impact for our patients, but also our staff, and hopefully improving those sort of outcomes for our population. So thank support with this one.
Thanks, Sarah. Yeah, really, really positive document, and really links in so well with the organisation values as well, but makes it crystal clear in terms of behaviours and in terms of our professions. So really good document. Any other comments or questions for Sarah? We're happy to approve. Excellent. Thank you very much. Thanks, Sarah, and thanks to the team for putting it together, and all those who've participated over the months in input into this. So thanks a lot. Let's move on then to item 14. Welcome to John. Hello, John.
Hello.
Equality, Diversity, Inclusion Partner. You're most welcome to the meeting. So we've got, first of all, we've got gender pay gap report. I don't know who's going to, is this going to be a double act between you and Vicky, or are you going to take the lead on this one?
I will absolutely let John take the lead on this one, but just a brief update here. He's here to provide a very brief overview of these 3 papers. They have been through the full trust governance process, so a lot of people probably have seen them already, but I'll let John do the talking from here on in.
Perfect. Thanks, that's great. So yeah, so we've got gender pay gap report first of all. We've got the next one is the disability equality standard, and then we've got the race equality standard. And you're quite right, they have been through all the various governance committees. So over to you, John.
Thank you and good morning, everyone. So for the gender pay gap, I'll take the report as read. And the gender pay gap report is here for final ratification, assurance having been provided through the People and OD Committee assurance report, as was just mentioned. But the key highlights really are that the mean gender pay gap has risen to 11.8% compared to 9.8% in the previous year. While this represents an increase on the previous year, and following questions at the People and OD Committee, I can confirm that more recent workforce data indicates that the gap is already reducing and is currently around 10.7. And we continue to be well ahead of the sector and the national figures. The underlying drivers and actions to address the gap are set out in the report. So therefore, we're here asking the board to approve the report for publication. Thank you.
Thank you, John. Any comments and questions from board members? No, we're all content. Excellent stuff. Happy to approve that. Thank you, John.
Okay, so moving on to the Workforce Disability Equality Standard. This is second of our mandated compliance reports. The Workforce Disability Equality Standard report has also been reviewed by the People and OD Committee, and it's presented today for that final ratification. But we've improved in 7 of the 10 metrics and continue to compare very favourably with our local system partners across a number of measures. In fact, we're sector lead in a couple of those. And encouragingly, we've seen a year-on-year reduction in reported bullying and harassment experienced by disabled colleagues. The report also helps focus our ongoing work, and particularly this year, we're looking around addressing presenteeism, that's staff attending work where they don't feel well enough to do so, and at the request of EMT, when we presented this EMT, to further embed the disability equality agenda across the organisation. So it has a bit of parity with the sort of anti-racism agenda. And again, the board are asked to approve the report for publication. Thank you.
Thank you. Any questions on this? Kath?
Thanks, Chair. Hi, John. Just a couple of questions, really. I think one of the items in here you've triangulated with the staff survey, which is really helpful to see that kind of information. It was the decline in reasonable adjustments, and what, you know, from an insight perspective, we've got plans of how we might improve that or make that more visible. What are your thoughts on the reasonable adjustments, John?
So interestingly, that figure has declined by that's about 2.5% on the previous year. We've been consistently high and consistently above the national sector. In fact, that score is joint top in the country, frustratingly so. If we hadn't gone down as much, we would be joint top in the country. So we have a very strong position, our staff are telling us, in our reasonable adjustments. But there is an action within the report to have a look at that. Why has it declined? What's changed? And so I'm going to work with the Disability Staff Network, and I'm going to work with Occupational Health and look at what it is that's changed, if we can identify it as something tangible, and then reinforce that messaging out in the organisation around reasonable adjustments. And I'm also working with Occupational Health as a plan to around how we communicate that more regularly, so that, because it isn't always a requirement that a reasonable adjustment has to formally go through the process. Managers can apply a reasonable adjustment very straightforwardly, and sometimes it's just giving the managers the confidence to do that. So can we work around that?
Yeah, that's good to know. And you just touched then a little bit on the staff network, because that kind of leads me on to my next question, was that is there a thriving staff network for disability? Because in here it talks about you're trying to engage those networks to build the trust, and obviously you just mentioned there about the reasonable adjustment. So is there a thriving staff network?
Thriving is an interesting word in this. It varies, but this is something that when I speak to my colleagues around the trust, and Pete Beckwith, my want to interject as the executive sponsor of the group, membership can vary. And it can be 20. The disability networks actually had the highest rate of engagement sometimes, but also it can sometimes be down to 5. And when I've spoken to my colleagues in the region and nationally as EDI leads, we get together, it's a similar story everywhere, work pressures and things like that. So we are working on that model of how we engage people. And previous chairs have tried to changed the times. They even offered one at a weekend to see if it would engage, or after hours to see if they could increase that engagement. So it's part of, as we're looking with it, to get a new chair involved, and we have a meeting coming up soon with an informal meeting where a new chair is potentially going to speak to some members and set out his ambition to see if that's something they want to do. And he's got some solid ambitions about how to improve that engagement. I see Pete wants to come in. I'll defer to Pete.
I was just going to add to what you said, John. I think we've had good attendance at the Disability Staff Network, and we've made some good adjustments coming out of that network. We've had requests for raising desks in bookable workstations, laptops on reception for people so that they don't have to carry laptops where, and those sort of things. So unfortunately, the network chair stood down about 3-4 months ago. So I think, as John's described, we're just in the process of rebuilding the Disability Staff Network. And, I think every chair we've had on the network has always tried to bolster engagement with it, Kath, and it's to varying degrees of success.
Oh, it's good to hear it's a live issue then. Thank you very much. Thanks, Chair.
Thank you. Carrie?
When I was talking to, John knows this and Sarah, because I emailed them afterwards, but when I was talking to Riddy from the Race Equality Network, she was talking about the attendance and how I was asking how, as a board, can we support that? Can we encourage people? And what Riddy was saying, which is interesting, is she finds it's the staff who aren't in control of their own, well, as you'd expect, I suppose, it's staff who aren't in control of their own diaries and working patterns that find it the most difficult, but in some cases would benefit from being part of the network. And she was trying to turn the lens around to look at it from the point of view of, could our team leaders and managers be a bit more proactive about saying, if you're saying you have a disability, or you're from a particular background and you need that support, could the managers do more to say, the network will be meeting, it meets quarterly, and we can, the dates are scheduled a year ahead, we can plan off duty, or we can plan time so that you can attend, be it in a work time or your own time. So it was an interesting conversation with Riddy, actually, and I think she's fairly newly appointed in that particular network. So it's I think we need to really nurture the chairs that we've got now, and try everything we can to keep them in place. But it was just an interesting comment from her about how to look at it a bit differently, really. It's not that people don't want to attend, it's that often things get in the way so they can't attend because they don't have that same level of control as somebody more senior in the organisation might have. So just an interesting point from her, really.
Thanks, Carrie. Yeah, and that might mesh neatly with item 18 about our frontline managers and etc. So yeah, really good point. Thank you. John, back to you.
So we just need to approve the Workforce Disability Equality Standard report.
Yeah. So are we happy to approve that? Yeah, lots of nods and thumbs up. Thank you. We're content with that. Thank you.
Thank you. So last one from me, the Workforce Race Equality Standard. Again, I'll take the report as read, and it's been thoroughly reviewed again by the People and OD Committee, and is presented for final ratification as with the other reports. But I'm really pleased to report that the trust has improved across the majority, all but one, of the RES indicators this year, and performance in a number of areas compares extremely favourably across the sector, particularly our region. We're very strong performing with the RES in the region. But while we recognise there's always things to do, and this year there'll be a particular focus on tackling racial discrimination towards staff from patients, the report demonstrates real sustained progress over the years, improving the experience and the opportunity of our ethnically diverse colleagues. And again, I'm here to ask for to approve the report for publication. Thank you.
Thanks, John. And I think that with this report, I'm particularly heartened to see some focus on how we provide staff with tools to address racism and build that into the confidence, the corporate confidence of the organisation in that way, to support staff and to support that challenge. So thank you. Claire.
It was just to say thank you to John for some of the work that he's done from a quality improvement point of view in relation to that. It is detailed in the report, but I think you're referencing to it, Chair. But in terms of that quality improvement to reduce racial harassment in PICU specifically.
Thank you.
Thank you.
Thank you. Are we Unless there's any other comments, are we content to approve that report? Yeah, thank you very much. Thank you, John, for your input and guiding these documents all the way through the various committees that you have done and the work that you and the team have done to pull them together. Really appreciated, really good work.
Thank you. Thank you very much.
Sorry, Chair, I did have my hand up. Sorry, I just wanted
Apologies.
to. No, it's fine. I just wanted to support and follow on from Claire earlier and just give John. I know the phenomenal amount of work that you do and how well you're respected in the system and the community as well in relationship to the work that you do. So thank you for that, and your passion is always there, which is what we want to see, and that's been Humber. So thank you so much for that, and you're really making a difference to the agenda, and it is so important. But on behalf of the board, I know we all endorse it as well, and as in what Claire says, thank you. And keep it up.
Thank you. Excellent. Thank you very much. So the next item on our agenda is a social values report, item 17. Kwame, you're going to introduce that.
Thank you, Chair. So I take the report as read. This is social value report is something that we as a trust are very passionate about. It's a way as an anchor organization to show and demonstrate that beyond our contractual obligations and commissioning obligation, we do more to support the community that we work in and live in. So the report has had different iteration going forward. This report, again, is linked to our strategic goals. So it's divided into our strategic goals. It has patient story, and we have also put tentative indication on how the impact is having not only on our community, but economically in terms of zero action and recruitment, working with a voluntary organization, and also how this is achieving financial gain in the long run. The report, I've just received the update of the report with the pictures and all the areas which from Rachel, and it really looks like a different report. I'll send it members of the board to have a look at that. So if there's any questions or any contributions that people want to talk about, but we are very happy about this contribution from the trust into the as a social value. Thank you, Chair.
Thank you, Kwame. Any comments or questions? Phil?
Yeah, I recently went out to East Hall 0 to 19 service and heard about their sort of initiatives to improve breastfeeding, and I just really want to reflect that to get a breastfeeding rate in a working class environment of 52% is amazing, and the change from 2008 is stunning. And so I just want to reflect that. And I suppose from a question point of view, some of the other stats are interesting, but I just wonder what sort of scale of intervention we should be aspiring to. And I'm struggling to know whether sort of social prescribing referral rates are good, and the number of volunteering hours, whether that could be on a totally different scale. I've struggled a little bit to make sense of whether that's good or it's just a start.
You want me to come in before?
Yeah, please.
Yeah, the conversation around breastfeeding is important to note, and as you know, Michelle is very passionate about breastfeeding and champions that within organization. In terms of whether, again, it comes down to the same question that Kath asked me about comparison in terms of national mortality rate, which compares each orthopedic surgeons with another orthopedic surgeon. So you can draw a graph and say it is gone. We don't have data which says 20 volunteer, but what we know is that year on year, we have a framework to improve upon that, and we have a framework to support our community, and we want to get as many volunteers coming to organization to help us. And so our benchmark is about improving upon it year on year, rather than to say compared to nationally, this is what people have.
Thank you. Yeah. So yeah, it's a good point, Phil. I mean, those comparisons and those improvements. But yeah, it's the sort of the direction of travel we're hoping for, isn't it? Yeah, and maybe, and we've got that in some parts of the report, but I'm just wondering whether for future iterations we should just be a little bit more where we can and where it's appropriate, just be clear about the direction we're looking for, and looking at where we're making big transformations, or actually where we're just sort of on a we're content with the level that we're at. Yeah, brilliant. Really helpful. Thank you. Kath?
Yeah, just echo the breastfeeding rate comments as well. I was speaking to a health visitor, and rightly so, she was really proud of some of the work that we're doing and the impact it's having, and it was really, really impressive. My question though is, there's some really good stuff in here to celebrate, etc. I guess from a strategic point of view, are there any of these that we think are scalable and then, you know, could be applicable to other services, especially, and I know I'm an accountant, I'm not always driven by money, I promise, but, you know, sometimes where you can see avoidable admissions. So I think the Scarborough, Rydale and Whitby Community Rehab Service, you know, they've got some really great data in there about how effective that has been. So are any of these in here we've kind of looked at from a strategic point of view and thought, actually, we could roll that out to X, Y, and Z because some of the principles have shown us that, you know, that pilot, that evidence base, etc.
Yeah,
I mean,
thanks.
I'm happy to come in there. I mean,
Yeah,
I
Michelle,
think
come in.
to a lesser or a greater extent, Kath, it's a really good question because it's something we don't do particularly as well as we could do, to be honest. I think we do in some areas, and it's what I mentioned this morning when we were talking to Justine and Karen about how we can utilise some of that learning across the organisation. And I know that Claire and the team have been trying to do a lot more of that through the transforming services work. So I think it's really good, but I think we do need to sometimes dissect things a bit more than we do. Like this report and say, well, if it's worked here, can't it work somewhere else? Just because it's a different modality doesn't mean it's not necessarily going to be, you know, and we talk about that as a wider system, and sometimes we don't do enough about it in the organisation. So we do need to get better at that, and that may be something the committees want to just think about when you're looking in the committees. You know, how scalable is this? How can have we tried it anywhere else? That might be quite a good question, to be honest. Just a thought.
Yeah,
Thank
thanks,
you.
Claire. Really good observation. Thank you. So if there are no further comments, are we content to approve the social values
Sorry,
report?
can I just, sorry, Steph, I did have my hand up anyway. Sorry, apologies.
Oh,
I did have my hand up.
apologies. Yeah.
No, don't worry, it's fine. It went down and I put it again. Just to say a couple of things. This isn't a finished document. Obviously, the content is. It will look more in keeping with our visual piece. There will be some visual pictures to go into there. And just to say to thank Kwame and others, because we don't have to do this. This is something that's not mandated, not every trust, in fact, very few trusts do. It was something that I feel quite strongly about, that we actually do demonstrate something where we just add that extra, a little bit of extra. So thank you for that. So some of the financial calculations in there do have a bit of a health warning on, and we just need to be a bit careful. I'm thinking obviously about the accountants in the room, because they are, you know, with all this, well, they are just sometimes indicative. It's really difficult. So I thank Pete's team for trying to put some financial calculations on this, but we don't have to do it, I think, is basically what I was trying to say, Steph, but thank you.
Yeah, thanks, absolutely. And that final point about social values reporting generally across different industries and sectors is not just about the numbers, it's about the narrative as well and the stories, very much so. So brilliant. Okay, content to approve the report. Look forward to seeing its full glory later on in the year.
Yeah.
Excellent, thank you. Thank you. So we're on agenda number 18 now, frontline managers, developing our people.
Thank you, and that's me, Chair. Shall I jump in? Thank you. So
Please.
this paper's here to provide an overview of the key themes that came from the 2025 National Staff Survey and then the preceding trust-wide listening exercise that took place. The key themes are looking mainly in this paper around the leadership and management capability within the organisation. It then sets out progress made so far,
outlines the key actions underway and describes the next phase of work. So when we looked at the 2025 staff survey and the listening exercise, which did include 91 teams who participated in it, so it's got a really good cross-section across the organisation, a consistent message came that the quality of line management remains one of the strongest influences in our workforce around staff experience, health and well-being, and around the organisational culture. It identified that staff really value visible, supportive managers, but there is variation across the organisation, and managers themselves identified a greater need for support with things such as performance management, feedback, having difficult conversations and coaching. In response to this, EMT and ODG at a timeout agreed strengthening management capability would be an organisational priority for this year, and a number of work streams were established, looking at things such as developing clear leadership expectations, strengthening our managers and managers' fundamentals, enhancing development opportunities, and supporting talent and succession planning. So those groups are underway at present now. But it's also worth noting that we do currently have a very strong offer within the organisation for our managers and leaders, and we are looking to enhance this moving forward. So the Trust has expanded the Proud Leadership Programme. We've redesigned the alumni offer. We continue to invest in coaching, mentoring and talent development within the organisation. We're also in the process of developing a manager's fundamentals programme, and we have a single point of access for development resources, tools and support via a leadership and management hub. It's also just worth noting, and it would be remiss of me to do this, that the publication of the NHS Leadership and Management Framework came out early July. This further validates the direction of travel within the organisation around leadership and management. A current review is taking place to cross-section around what we do, and any gaps are being picked up there. But currently what we see is what we offer is clearly in line with a lot of the work in that national framework. I'll leave it there and take any questions.
Thank you. Any questions or comments on this report? Kath?
I really like this report. I thought it made a really, really good read, and I think it showed how Humber's taken the staff survey results and then just gone a bit further and delved a bit deeper to give us some of the real reasons behind some of the scores. And I thought that was really to the organisation's credit. So really supportive of the proposal, because it's kind of based on the evidence that you've provided of this is what people are telling us. And I think the honesty of supporting line managers, I've lost it in my pack now, where it talks about that confidence in applying performance management, sickness management, etc., coaching and difficult conversations. We have a lot of those in the NHS, and supporting staff with those is really, really important. So really, really supportive. I like the proud leadership that you've come up with. I guess one of the things we'll measure the effectiveness of this by would be the staff survey, and obviously that comes around annually. I was just keen to understand if we've got any way of kind of interim evaluating how the impact is going on those people who are going through the cohort.
We do have evaluation of all of the cohorts anyway, and we are looking to enhance that as well, to kind of go back and do a bit more of a deep dive into what's happening within the workplace when they've completed those cohorts as well, the impact it's having there. That is something we are picking up within our learning and development team for them further to enhance that evaluation of the courses.
That's brilliant. That's good to know. Thank you very much.
Thank you.
Thank you very much, and thanks for the report. Really important roles in the organisation, aren't they, in terms of delivering to our patients at the front line, and setting out the values and expectations of all our staff and our teams. And I'm really glad to see that you've managed to create a little bit of capacity within your teams to support this process. And I guess it's something that particularly our People and OD Committee, from an assurance point of view, will want to keep an eye on. Andy, you wanted to come in? Andy?
Yeah, sorry, Steph, I was just on mute there. Just a general point. I just wanted to make the point that I wanted to support this. It's a superb initiative. These things don't happen by accident, and the frontline managers are the engine of the organisation. So this kind of work is bound to have a profound effect, I think, on how things work. So absolutely support it. It's a super report. Well done. Thank you.
Thank you.
Thank you. Yeah, so we've obviously we've had the presentation discussion, and we're content to note this report and support the objectives. Excellent. Thank you very much. Let's move on with thanks to the team there for pulling this together, and we'll move on to the finance report. Pete.
Thanks, Steph. So this is the report as at the end of the June. You know, folk on the board will remember that as a trust we have a break-even plan for 26-27, and that plan has been signed off by NHSE as compliant. You can see from the report that at month 3 we recorded a break-even position year to date, and we continue to forecast a break-even position by the end of the year. Our cash position and our better payment practice code position both remain strong, and they are also good indicators of financial health. And just very quickly, you'll note in the report, we've started to report resident doctor pay errors. We haven't had any, and we very rarely do, but part of the 10-point plan requires us to report to board if we do have resident doctor pay errors. So I will stop there, Steph, and happy to take any questions.
Thanks, Pete. Any questions? No. Happy to note the report. Thank you. Let's move on then to the performance report.
Yep. And I think that's again me, Steph. So this is the updated version of the performance report where we now have the individual commentary for each section, such as quality and workforce. We've also got, for the first time at the board, the finance section included. We have seen that at exec, but obviously this is the first time it's come to the board. I guess some quick highlights, and then we'll move straight to questions. Is we have maintained strong oversight framework performance at Q4. You know, we're currently working through the 26-27 oversight framework, but NHSE haven't published the technical guidance. So when that comes out, we'll take it through the appropriate governance route. You know, with continuous strong performance across a range of metrics, training, clinical supervision, CPA, mental health agent response, community response are all really strong. You know, and we've highlighted in the report, which again, there's no real shocks in here. Sickness and perinatal access continue to be an area of challenge. And talking therapies has popped up as an area of challenge in this report, but we know that's linked to acuity, and we are doing a piece of work within the division to understand that through the gateway review process. I will stop there, Chair, and we'll just move straight to questions.
Thank you, Pete. Questions or comments on the performance report? Phil.
Yeah, thanks for the report as always, Pete. Really good. Can I have 3 questions?
Of course you can, Phil.
One is about East Riding talking therapies. It's been a bit of a it's been a bit troublesome for a little while, but it's not probably one that gets a lot of focus. We've not hit the 18-week compliance rates. Really, 18 weeks is a backstop. It should be 6-week compliance, really, for a sort of fairly primary care-based intervention. And it seems, you know, that it's been put down to increased complexity and changes to acceptance criteria. But actually, if you look at the trend graphs, we haven't. It's been sort of deteriorating a little bit over the last 2 years. And I just wonder if it's time where they added a deep dive, maybe at Quality Committee, to understand why this is not where it should be. So that's one. And then just a quick question about virtual ward admissions. They peaked at 45 in 1 month, but they seem to have dropped over the last few months down to about 30, 32. I just wondered if there's any reason. And then last one is about out of area placements, which is obviously a critical performance thing for us. And that's showing signs of increasing, which seems to be due to older people. I just wondered why that was. And I know on PQ, once we've got the female HDU in Town and Court, that should sort that area. But so it's about elderly out of area placements, what's happened to the virtual ward admissions, and particularly about talking therapies in East Riding.
Thanks, Phil. I'm hoping Claire with your hand up is going to answer some of that for us.
I've written them down, so it's a case of I'll take them in turn if that's okay. In terms of from a talking therapist point of view, what you'll see is that the reliable recovery is really good, which is actually the outcome ultimately. In terms of the 18-week position, when we talk about the pathway for talking therapies has changed. So when we talk about acuity, they're basically seen in blocks. So you see a block of therapy. So it's a case of the pathway for the patients and elongated, which is actually put pressure on the service. That's why we're doing a deep dive to actually determine what we need to do differently in order to make sure we can maximise on our capacity. So it is a capacity issue, even if it doesn't look as if referrals have increased. It's a case of the acuity of the patients is more challenging. So I think it's a valuable point, and it is something that we are already on with and we're already looking into to say how can we reconfigure the service. So I hope that provides assurance that it's something that's in our line of vision and we are focused on that, but we're also making sure the other metrics remain good, which is the outcome for the patients, which is a real key, which is that reliable recovery element. In terms of the virtual ward, the referrals have dropped. It's a case of it's something that we actively promote to make sure that we identify patients to access the virtual ward. In some respects, what we're doing is we're diverting the patients in the first place by giving that intensive care anywhere in the community without them actually having to access the virtual ward in the first place. But in terms of, I'll get a further update from the service in terms of what they're doing to try and sort of promote the use of it more with our partner colleagues. And in terms of the out of area referrals, it's a case of, you're right, it's the older adults that are our biggest challenge. That's been our biggest challenge from a delayed transfer perspective. So there's some real positive news with East Riding, where they have provided us with a social worker on our older adult ward to try and improve discharges so that patient flow is much better. And we've also got an initiative that's underway to develop some step up older adult beds that we discussed only yesterday at EMT. So it's a case of those initiatives we feel are what going to bring those out of area referrals down. I hope that helps.
It does help, Claire, but once you've done a bit of that deep dive into looking at talking therapy, it'd be useful if you share a little bit with that with Quality Committee, so we can first understand and then make an assessment based on better understanding of what's going on.
Yeah, no problem.
Thank you. I've got anything else from you, Claire? Are you?
No, sorry.
No, that's fine. Michelle.
Yes, on the talking therapists, I mean, great responses, Claire. I'm not going to build on that at all. Some really good questions, Phil. Claire, it might be useful to have a conversation with Alison about the talking therapies, because actually we're not an outlier. Actually, we're one of the better trusts in the actual region in relationship to talking therapies. I'm not certain it's not a problem, but that's due to the level of funding as well. So it is something that we've looked at from across the system point of view. And looked at, I mean, that's just our organisation, that's not the HMY system, because obviously there's some providers within there that are in a more deteriorative position in relationship to talking therapies, and we don't provide all talking therapies across. CHCP do provide some, I believe, as well. So if we are going to just do a briefing paper to Quality Committee, which I don't think it's a bad idea, it might be useful, Claire, just to put some of that context in relationship to the national and the regional picture, to be fair, just so you can get that balanced view for, because I know it's something that GPs do keep alluding to, but it's not the panacea of everything in relationship to mental health, and we've got to look at the resources we've got, because it's really clear there ain't going to be any more. So it's how we utilise it and how we use it within the organisation, but also just to get that overview of where we're at in the system would be helpful, I think, and will be helpful to Phil.
Yeah.
Thank you. Yep, thanks for that. Yeah, if we could note an action around the talking therapists update to Quality Committee in due course. I noticed on the virtual wards that in the early days there were some issues around promoting the virtual ward, and that we seem to have got over that hump. And I'm just wondering, whether that needs a refresh, or we've got different groups of clinicians we need to address, and different cohorts of patients potentially that we need to address around that. Yeah, superb. Any other questions around the performance report? Okay, content to note that. Thank you very much. Collaborative committee terms of reference. Stella.
Yeah, okay. Trust Board approved some changes to these terms of reference in May, but since then there's been another proposed amend, and that relates to the chair and vice chair roles being occupied by non-executive directors, and that's just detailed within the paper, and they're here for approval.
Okay, yeah, this is the committee I chair, and I think this was something that sort of went under the radar. I'm content with it. Are we happy to approve those changes? Thank you very much. We're moving now to the assurance reports from the various committees. First of all, Finance Committee, Keith.
Thank you very much, Chair, and apologies for this being verbal, but the committee was only held on Tuesday of last week, and we didn't have time to get the report into the papers, otherwise it would have delayed your board papers, so apologies for my verbal one today. As a committee, fully assured on section 1, which is grip and control. Pete's already put his finance report through, but we're on budget for month 3, good cash and capex position for the trust, which is really good. Worth noting the significant fall off and significant pressures in the wider system that we sit in. We are the only trust that's delivering currently to its budget, and the deficit position is increasing for the wider ICB and other organisations, and obviously that puts significant strain on the system, so it's worth noting that for the board and being aware of that. Interestingly, just for the board to be aware that the new regional chair has called for the first meetings to be set up around finance committee chairs from all the organisations, both across the ICB, but also, interestingly, more broadly across the whole region. So we may have finance committee chairs meeting from the entire northeast region. Haven't got a date for that yet, but interesting to talk about ways of working and to talk about the overall financial situation that's affecting all organisations. So we'll see what comes from that next time I report back, hopefully. Section 2, fully assured, which is around efficiency and productivity, continuing focus on making sure that our BRS data, and particularly some of our productivity data, still delivers really clear insights, but good progress has been made. The NOF position reflects that, and that's a position that's improving and reflects the amount of work being done by the organisation. We saw a deep dive into agency and bank use, and that's primarily around the focus that's being driven by NHS England to ultimately completely reduce agency use to nothing and reduce bank staff use, which is, although we are delivering to those numbers, represents an increasing challenge as you get towards zero effectively, particularly of agency use, although our current agency use is very low. And we saw a deep dive to reflect and make sure that we're in the right place, which included also a very helpful update from Kwame, particularly around consultant recruitment and consultant vacancies, which is one of our biggest agency risks or bank risks in reality if we don't have consultants in posts. And I think I'm remembering back to my notes, but I think Kwame said all but 2 consultants have are now resolved, and that minimises our risk in terms of those results. Section 3, Steph, I won't go over the digital. We registered a part assurance. We've talked about that enough today. And the only other element, which we've also talked about, the board's kindly approved, was the changes to our title and relevant terms of reference, but membership of the group doesn't change. The committee hasn't changed. It's just the title, and we've reflected that in the terms of reference. I think I will stop there, and unless there's any questions, Chair.
Thanks, Keith. Really appreciate that update. Any questions for Keith? No. Thank you very much. That's all noted. Let's move on to People and OD Committee. Harry.
Sorry, just unmuting. So the committee met, it was a shortened, sorry, the phone's ringing, a shortened version of the People and OD Committee this time, and it was primarily to approve 4 reports, 3 of which we've covered fairly extensively today in the meeting, which is the gender pay gap, the workforce race equality standard and the workforce disability equality standard. So I won't cover those again, obviously we've just talked about those. So the other paper that we approved was the workforce plan. And in terms of the workforce plan, we did approve it. Key priorities we noted included the growth in children's and learning disability and community services, the expansion of advanced clinical roles and apprenticeships. We talked about succession planning for an ageing workforce and recruitment, the need to recruit over 200 staff while reducing the overall establishment through service transfers and efficiencies. So we talked about the current workforce challenges, which was around the vacancy factor of 7.22%, which equates to, I think it was around 250 current vacancies. The highest vacancy rates being in the allied health professionals, healthcare scientists, and in the bands 2 to 3, and in community primary care. Turnover was above target at 12.34%, and nearly 22% of the workforce were approaching retirement age. So there were some of the challenges that we talked about. And the committee, we had a good discussion about that, and I've included the discussion in the actual report itself. But we asked for future plans to include clearer workforce movement data, greater emphasis on digital transformation and AI and how that might be built into future iterations of the workforce plan, and looked at whether or not we could do wider benchmarking beyond beyond NHS trusts. I think some of that is done already, but they were the sort of things we talked about. So overall, we concluded that we were making strong progress across all the key areas in the People and OD Committee, so workforce equality, inclusion and organisation development, and we were performing strongly against the national benchmarks. I think that's probably where I'd stop, unless people have specific questions.
Thanks, Carrie. Any questions?
Sorry, I've got a frog in my throat today.
Oh, you okay? All right. Very good. Thank you. Happy to note that report. Next, it's me, Specialised Collaborative Committee Assurance Report, which you've had in advance. I just wanted to highlight a couple of things. First of all, there's nothing really outlying in the work of the group. A couple of things. It's already mentioned earlier, right at the start of the meeting when we had Karen and Justine, the radical reduction in the use of nasogastric tube, NG tube feeding with children and young people. Just to put some figures on it, reduced from 2024, 548 feeds down to, in Q3 26, down to 3, so 458 to 3. And that's due to a really radical changes and improvements in therapeutic intervention and putting the patients at the centre of what we do. So really good results, and yeah, just reflects some of the work of the provider collaborative. We've approved new workstream priorities for 2026-27, and we've looked at approving a most suitable provider approach for the adult eating disorders alternative to admission service in North Yorkshire and York, which we ratified. So that's one of those important services which is seeking to intervene before we get to the stage of people needing to come into inpatient services. So that's really good work there. All our providers are subject to routine quality assurance monitoring. We're in a positive financial position as a collaborative, and we've received recently very positive feedback from NHS England on the approach we take to developing new alternative to admission services in general. So just a few things to note there. Happy to answer any questions. Okay, happy to note that. And then Quality Committee, Phil.
Yes, this is assurance report relating to a meeting we held on the 4th of June. Just a few highlights, really. There seems to be loads of recommendations coming through from national inquiries. relating to leadership and board oversight in trust. And I think EMT is looking at this in the first instance, but it will have some impact on us as a board. Sort of venous thromboembolism assessment still an issue, and some of the issues are more down to the criteria seem to be more suited for acute hospitals than ourselves. But there's a deep dive, and it's going to be reported to CPAS. It's actually in August 26. It says 25 on the front sheet, so that needs to be amended. We approved the quality accounts due to the fact that there was national deadline, so that was delegated to us from board. From Quality and Safety Insight, there was focus on falls, pressure ulcer prevention, incident review timeliness, the improvement at Hull CMHT, and the fact that the family and staff guidance under PSERF has been delayed, but that's due to us trying to do it right and involve family and staff. The next meeting of Quality Committee at the end of August, we'll be looking at the new BAF, and we'll be having a focus on enhanced prevention, wellbeing and recovery. I'm happy to take any questions.
Thanks, Phil. Any questions? No? Happy to note that report then. Thanks, Phil. So moving on, item 26, August Board Strategic Development Meeting Agenda. We've got the agenda there in front of us. So annual review of risk appetite is something we'll be looking at. Implementing outcome measures at the Trust, which is something we've touched on a couple of times today. We'll be looking at that too. And we'll be having a briefing around culture. Any other items people would like to see in that agenda? Any comments on that agenda? Are we all content? Okay. Yep. So that is noted. Thank you very much. So from today's meeting, any items to escalate, including high-level risk register or for communication? I've not picked up anything. I've gone along. Just want to make sure I've not missed anything during the meeting that we need to escalate. No. Okay. Nothing to note there. And has anything on the agenda contributed to improving the board assurance framework position? Anything anybody would like to highlight in terms of our improved position? Nothing to note. I think we've oh, go ahead, Michelle.
It might be worth having a look at the crisis good report in relationship to the quality piece, if we've not done so already. Steph, that was in the chief exec's report.
Yeah. Are we okay with that? Yeah. So if we could just note that for the minutes and make sure that's carried forward. Thank you. Any other business? Anybody got any other items? No, thank you. Review of the meeting. Have we focused on the right areas? Any comments on the quality of the papers? Did we have the right level of discussion? We all content? Any issues that anybody wants to raise? I personally thought the quality of the papers were very good today, really focused, really easy to read, which is always helpful. And the quality of the presentations was really good, straight to the point, which is what we like. Thank you. Was the debate allowed to flow? Was everybody encouraged to contribute? And have we operated in line with the Trust cultural and behavioural standards, being humble standards? Michelle?
I'll wait for anybody else, but just say well, Chair, because I thought it'd been a good meeting. Thank you. I think you steered us very well in Caroline's absence. I think you've done very well in relation to the papers. So, no, well, Chair, thank you. From my point of view, I'm sure others would agree.
Thank you. Yeah, and thanks to everyone for your support in making it as easy as it could have. It could have been a lot worse. So thank you. Thank you so much for your support today. I mean, actually enjoyed the meeting. I've enjoyed everybody's contributions, so that's brilliant. Good work. So we'll conclude the meeting there. It's 12:26. If everybody can just stay online for a moment, if we can switch off now.